Welcome to the Shropshire CCG board meeting. I'm sorry we're a few minutes late. We'll just wait for Simon to take his seat, and then we'll start.
Never had a badge before.
There's one on here about the admin reduction, which is where we all get paper, but then we pulled it. It's got my name on it, but if I just do a quick, just a public, in public acknowledgement of it, and then I'll just say, sorry, have you got anything to add?
Do you need to ask me to have anything?
Could you say, are there any questions or comments? And at that point, if you've got anything burning, you can shoot in.
She's not here. She's not here.
So thank you very much for attending the Shropshire CCG board meeting. We only have one apology, and that's from Dawn Clark, who unfortunately has had to cancel at the last minute due to ill health, and therefore we have her deputy, Sam Bunyan, who's relatively new at the CCG, sitting in, so thank you very much. Before we do members of declarations of interest, I'd just like to say we've got some new board members present today. We've got our locality chairs for the north and the south. So we've got Dr Michael Matty, who's a GP and market director, who's the chair of the north locality, and Dr Matthew Bird from Albrighton, who is the chair of the south locality. So welcome to you. We also have our new secondary care consultant, who's Mr Alan Lehman, who's recently retired, I think it's fair to say, from a long service at South, working in A&E. We'll go round and do the declarations of interest, and then I'll do some introductory comments. So I'm a partner in Ponsonby Medical Practice, and my wife is the medical director at the Community Trust.
I have no declarations.
No declarations for me.
No declarations from me.
No declarations. No, thank you.
I have a relative that works at South.
No declarations.
No declarations.
No declarations.
My wife is a member of staff at South.
No declarations.
No declarations for me.
I'm an employee of Shropshire Council.
I'm a GP partner at Albrighton Medical Practice, and I'm a GP appraiser.
No declarations.
So you're a partner at Market Trade?
Sorry, I'm a partner of Market Trade. I do apologise.
No declarations.
I'm a GP partner at Belvedere Medical Practice, which is part of the Darwin Group, and a GP appraiser.
No conflicts.
I'm a managing partner at Cambria Medical Centre in Oswestry, and my wife is exec nurse, voting member at Telford and Wrekin.
I'm a salary GP at Bishop's Castle. My husband locums for Shop Doc.
And you've broken the microphone. My dad's county councillor and is also on the Board of Governors for Wormhouse.
Just a few things to begin with. One is that two of our board members, so Julie Davis and Gail Fortsmeyer, are actually on call, and as we know, there's challenges at the hospital, so if they're seen to be on their phones or social media, it's actually trying to sort out the problems that our providers. Our constitution has been updated and put up on the website. The main changes around voting members, and that our fourth lay member, Sarah Porter, is now a voting member of the board, and Professor Thompson is the representative of public health from the local council is here as an observer on a participant on the so not an observer on the board. So thank you. We've also obviously had the release this week of the NHS long-term plan, which is 136 pages of vision and direction. A lot of it is supporting what we've been doing in Shropshire, for example, around our care close to home, and around our 0 to 25-year-old service for adolescents and young adults. There's a lot of other elements within that around changes in prevention and different ways of working, including sort of digital healthcare. So we do welcome the long-term plan as being able to allow us to set direction for the next 5 to 10 years. That's been backed up by a 3.4% increase year on year in NHS funding, which is, whilst welcome, is possibly not enough for us to see a wholesale transformation without other changes, but we'll certainly give it a go. And that will come out through some of the work we're doing over the next few months. And I think part of the long-term plan is there needs to be a plan by the end of April, I think, towards that. So if we move on to the minutes from the previous meeting that was held on the 14th of November. If we check them first for accuracy and correction, so there's pages of the pack, it's page, well, the minutes is pages 1 through to page 8. Then from page 9 through to page 14.
I just have one, please, on page 13, just to be absolutely clear. In paragraph 15.2, there are some, 15.1, in the finance section, there are some bullet points. The third bullet point down, the final sentence of that says it was reiterated that the Commissioner Support Framework payment was not money which would benefit the financial position in year. It would help the CCG by stopping the CCG's accumulated historic deficit. So it does absolutely help by stopping the accumulated historic deficit. It does help in year because it stops that deficit in year. What it doesn't help is our underlying position moving forward, because it's only a one-off payment. It doesn't permanently occur. So it's just for that clarity, really.
Okay, thank you. And then pages 14 through to page 20. And then page 21 through to the end of the minutes on page 24, 25. Then that leads us on to the matters arising, the actions arising from the meeting. The first 4 actions are all complete. So the bottom one on the first page of actions was Dr. Freeman to bring back to the next meeting an update on system IT resource to unblock issues, prevented data sharing with the community trust and providers. That was for the January meeting. Is that's not on the agenda today? So is there?
I might have to bring that back, I'm afraid.
The next one is on the agenda today. That's a report on the BU service. The next action was to regards with Dr. Freeman suggested the performance data on tumour site be included in future corporate performance
report.
reports.
And we fed that through, and that will come through in March's performance report.
In March, brilliant.
Yeah.
Next one is Dr. Davis arranged communication to reassure patients and practices that South remained a safe place of elective surgery. It's been done. And then Mrs. Tilly-Sam to seek approval of amendments to the Constitution. So that's been done. There are a couple of outstanding points on the Sam that...
I have confirmation it's now been approved.
I don't think we can hear you, sorry.
I have confirmation from NHS England that it has now been approved.
Good, thank you. So that'll be up on the website. The final action was to feed back through the SDP Mr. Sambat's suggestion for providers to have a patient's portal. Is that,
I don't think anybody disagrees with that.
It's been fed back, yeah.
Yeah, it's within the local digital roadmap, I think. Yeah.
Unfortunately, Dawn isn't here, but I was wondering if anyone else who was at the CQR knew whether Dawn was able to feed back Mrs. Bickerton's comments on her patient experience via the CQRM. Do you know if that happened? No, were you at the CQRM? Or should we defer that to next time and ask Dawn? Okay, that's fine. Thank you. We then move on to our new section, which has aroused some questions, which is our public questions. The board have decided that from now on to allow to allow better answers and to allow more time and to keep questions onto subjects that we're actually dealing with on the board, that board questions will now be in a written form submitted up to 48 hours before the meeting, and that a summary will be provided back at the meeting, and then a formal written response will go back to the people raising the questions.
Can I ask you, Chair, does this mean that we will be unable to ask questions about what's happening at the meeting during this session?
Yes.
Yes. Thank you.
So is this an attempt to muzzle the public and patients at a really critical time for reorganisation of the health service in Shropshire?
If I read through some of the questions, because those have come through some of the written questions, and you'll have the answer through some of these questions.
Quite often there are things happening in the meeting which is important.
It's not the. But if I read the answers to the questions and then the answers back, then I think that will cover some of the points you're
Will
raising.
we have time to actually question you about your responses? Because quite often you give quite vague and general terms. So
no, and I've said we will.
You're muzzling discussion, are you?
Wouldn't say. No,
Just
not
to be
the words
clear,
we'd
this
use.
is not a public meeting. It's a meeting in public.
But we have always had a chance to actually challenge and to...
That's not the point of this meeting. The point of this meeting, it's a meeting in public. It's not a public meeting. It's where people get the opportunity to watch the CCG go through the decision-making process. It's not actually the place where challenges and questions are issued as an ongoing meeting. It's not an ongoing discussion. And we're in line with a lot of other CCGs and in line with NHS England, which clearly at its own board meetings you have to apply to attend, and they don't take any questions at all at the meeting. And we're in line with other CCGs. We have looked into how other CCGs handle public questions, and we've found that, for a number of reasons, that in fact we think the meeting will be more effective and will allow greater transparency to the public if we stream the meetings on a regular basis and actually deal with written questions with items that are on the agenda.
There are many members of the public, some of whom are here, who think that this will lessen our attempts to actually, or transparency, for us to have any kind of genuine input into what's happening in our health service in Shropshire.
It's not the point of the meeting. I mean, we've made the decision, and we've got some questions now which I intended to go through, and but thank you for making the point.
Discussion on our questions. We don't have a chance to actually respond to if they're bland and rather off-putting. We don't have a chance to actually say so.
No. You don't have to attend the meeting if you don't want to, and that the meeting is here about enacting NHS business, and it's the transparency of watching the meetings. We're very much in line with, certainly in line with NHS England, in line with a lot of other CCGs around the country as well. And
in terms of other CCGs, our parallel CCG, Telford, does not expect written questions submitted 48 hours.
there are different CCG. We undoubtedly CCGs these do.
Not all CCGs expect that written questions are submitted 48 hours.
No, and we've decided that they are our CCGs, so that's the way we're doing it. So I will move on, and I will deal with the questions that have been submitted. And as I say, the CCG have got many ways of doing that. Thank you.
Interaction with the public.
Okay, thank you. I don't think you can write in then, because we don't have a way of doing that within the board meeting. So you're very welcome to write a formal complaint into the CCG. You're very welcome to write to NHS England with a formal complaint. As a CCG board, we have made that decision. And, say the meetings are live streamed. The meetings will allow people to observe decision making and how it affects Shropshire Health.
Far too defensive. Far too defensive.
Thank you. So the first questions were submitted by Jill George. The first question was, why does the board believe it is necessary to end verbal questions from the public? When was the decision taken and by whom? Does the board believe the decision is consistent with the Nolan principles? Does the board believe it is appropriate to prevent the public from questioning any item that arises during the board meeting? Does the board accept that the combination of this and the move to 2 monthly meetings will make it harder for the public to follow and or query the CCG's decisions and work? Is it the board's intention to accurately minute questions and answers? So this is the CCG response. The governing body reviewed its approach to public questions at its confidential meeting in November 2018. This review was timely as the process of public questions had not been reviewed since October 2016. On the basis of this review, the governing body concluded that in order to appropriately balance the need for the CCG to make decisions in a transparent and open way with the need to ensure decision-making at governing body meetings remains streamlined, that it would be moved to a position of written questions. This ensures that questions are not limited by time constraints and that fuller considered answers can be provided. This continues to be in line with the Nolan principles. The governing body does not accept that the combination of bi-monthly meetings and written questions make it harder for the public to query the CCG's decision-making. The guidance issued on the CCG website makes clear that questions and their summary responses will be recorded in the minutes. The second question is around elective orthopaedic activity, and it's why is elective orthopaedic work diverted away from SATH to the Nuffield, with a consequent loss of income for SATH, and the same surgeons carrying out the work. This was discussed at SATH's 25th of October board meeting and is of concern to SATH. Is this contract administered by the Community Trust, and if so, why? Does Shropshire CCG believe this is a sensible use of NHS funds? Shropshire's CCG answer to that question is Shropshire CCG has minimal activity at the Nuffield. This question relates to a service for Telford and Wrekin CCG, and we'd highlight that under the current NHS choice arrangements, patients have the right to choose between providers. Question 3 from Mrs. George. What contracts does the CCG hold with private sector providers for ophthalmology services? Does the CCG know of any subcontracts between NHS providers and private sector providers? Is the CCG happy with the quality ophthalmology services provided locally by private providers? The CCG holds contracts with private providers for community ophthalmology and community optometry, which includes glaucoma repeat measures, PAIR scheme, cataract referral refinement scheme, cataract follow-up scheme, children's eye care scheme, and ocular hypertension scheme. We're not aware of any subcontracts made by NHS providers with private providers for ophthalmology. For community ophthalmology, the provider is achieving all their KPI targets. The fourth question, what is the involvement of GE Finnemore in Shropshire's community service review? Will the CCG share information on GE's role and share the output of GE's work? The answer to that, GE were not engaged by the NHS to assist in the Shropcom sustainability work.
Sorry, the GE were engaged by NHSI to assist in the Shropcom sustainability debate, but nothing to do with the Shropshire Community Services Review.
What is the timescale for implementing a single integrated health and social care record locally? Is funding for the project agreed? The question is sharply relevant given a recent inquest in which a failure by the NHS to share information across organisations was found to have contributed to a patient's death. The local digital roadmap is a strategy for digitally enabling the health and care system across Shropshire County. This fits in with Care Close to Home and the hospital redesign programmes. Funding is identified from within constituent organisation capital plans. The Digital Enabling Group and the STP Leadership Group have oversight of the process. There have been some central funding to support local health system implementation of the digital programme, of which a digitally enabled health and social care record is a key component across Shropshire. Progress is already being made on extending the information available from GPs to other organisations and towards providing digital patient records across all trusts to allow them to eventually become part of an integrated health and social care record. We then received some questions from Jane Astley-Berry. First one was only 1.9% of people completing the FutureFit surveys give any indication of support for the FutureFit model. Does Shropshire CCG believe that opposition on this scale is best dealt with by ignoring it? The response to that is the consultation is not a referendum and the consultation is being conducted openly, transparently and in accordance with relevant legislation. Second question is, what are the results of the ambulance modelling around FutureFit? Why has the CCG not released these results? Why is this information not in the public domain? The answer to that is ambulance modelling outcomes have been shared with both the HOSC and the FutureFit programme board. There's a subsequent question from Ron Berry. He's not at the meeting, but it was about the rules on submitting questions in advance, and the answer is the same as given on to the Jill George question. Question 2 from Ron Barry was, Care Close to Home, will the CCG make a commitment that it's closer Care close to home proposals will not involve further closure of the community hospital beds. And the answer to that is phase 3 of the programme will look at the physical assets, including beds. This element of the work has just commenced.
Can you slow down, please? It's quite difficult to actually absorb what you're saying if you read at a rate of knots.
Okay. Thank you very much. And, I will try. I did try and slow down, then I sped back up again. You're right. It's a flaw of mine. Further questions then from Janet Cobb. Given the attached patient safety record at SATH, and she attached an attachment which will be available in the minutes, what actions have been taken or planned to improve patient safety at SATH? The answer to that is and obviously it's on the board later on, but the CCG takes patient safety in all its commission providers very seriously. The quality and safety of provided services is assured through quality schedules, commissioning for quality and innovation indicators, and monitoring of quality, impact, innovation, productivity and prevention schemes and site visits of providers. As a major provider of local services, SATH meet with the CCG through the Clinical Quality and Risk Review meeting and Maternity CQRM monthly, where a range of quality and sequence indicators within the contract are monitored. These indicators include patient safety issues, complaints, serious and untoward incidents and other indicators of quality. Issues are escalated to the SATH Strategic Clinical Commissioning Board, CCG Quality Committee, the CCG Governing Body and NHS England Quality Surveillance Group. The patient experience, safety, clinical effectiveness and safeguarding expectations for the 1920 SATH contract have been further refined to offer increased assurance and a greater level of consistency across the Commission service. Follows a question from Janet Cobb on FutureFit. Why is FutureFit not being scrapped? Capital funding of 300 million is now available, and to spend this on trying to upgrade obsolete buildings on 2 sites contaminated with asbestos is frankly reckless and stupid. Closure of both A&Es to be replaced by 1 emergency centre and 2 privately run UCCs will not resolve the long-term problems in Shropshire, resolve the clinically dangerous situation locally. The answer to that is FutureFit has been through a clinical-led process assured by NHS England and is consulting on clinically and financially viable models, and no decisions have been made about the provision of who will run the UCCs. Then follows 2 questions from myself, Sylvia Jones. How does the CCG's continuing and worsening financial crisis affect funding for the Care Close to Home project? The deficit financial position of the CCG is, of course, a concern for the governing body, and we're working hard to return the CCG to financial balance. Our current financial plans continue to include a working assumption that there will be a requirement to reinvest a level of savings generated from reduced admissions to hospital into out-of-hospital services in support of our Care Close to Home agenda. A second question from Sylvia Jones was, we hear routinely about the CCG involving patients in its future decisions on services and reorganisation, yet you've now decided to hold public board meetings every other month instead of monthly. You can now hand-pick patient representatives to attend CCG planning meetings. A highly regarded and well-attended patient information forum has been quietly dropped, and now you propose to stop the public from asking questions about discussions at board meetings that directly affect them, effectively telling patients to mind their own business. So much for involving the public. Have you forgotten who really owns the NHS and who you're supposed to be caring for? The response to that is, prior to the CCG being placed in legal directions, the CCG held its public governing board meetings bi-monthly. As part of being placed in legal directions, NHS England required the CCG to meet in public monthly. In recognition of the progress made by the CCG, NHS England have now determined that we can return to public meetings bi-monthly. The CCG uses a range of means in which to involve patients and the public in its work. The CCG has not stopped the public from asking questions of the governing body. It has made an adjustment to the way in which it's done. There follows a final question. This one's from Francis Robbs. Your proposals for the future of our health service in Shropshire talk about care closer to home. The words sound good, but I'm worried that it really means volunteers looking after people and the rundown of community hospitals. Can you assure me that this proposal does not mean reducing beds in the community hospitals? We have now received the joint needs assessment from the local authority, and phase 3 of Shropshire Care Close to Home will use this to ensure we have sufficient beds across the county to meet our population needs. This will be a mix of community hospital beds and local authority specialist provision. So those are the public questions that we received this month. And again, the individual people will get replies back from the CCG, and those will be attached to These will be attached to the minutes as well. So we then move on to the first paper on the board, which is Sam Tilley presenting the Governing Body Assurance Framework.
Thank you, Chair. As you well have noticed, we have moved this agenda item to the beginning of the meeting. This is to allow the discussion of the GBAF to precede any of the other items on the agenda, so that the risks highlighted on the document can be at the forefront of people's minds when undertaking the discussions that will come later. As you will see from reviewing the document, we are managing a range of risks, and there is evidence to suggest that despite the nature of some of these risks, we are managing to maintain a reasonable position. I would like to draw the board's attention to the addition of risk number 11 as a result of discussion that happened at a previous governing body meeting around the 0 to 25 service, and would ask that any comments are forthcoming.
So any comments from the board about the Governing Body Assurance Framework? No. If not, then we're asked to note the inclusion of the risk number 11, the management of the 0 to 25 health and wellbeing service, and to note the assurance framework. So thank you. Next one, we move on to a verbal update from Simon Freeman on the commissioning landscape.
Right. This is just really to bring the board's attention to the elements of the NHS plan, which looks at the development of ICSs, ICPs, and the future for CCGs, and also align that to a very clear indication from NHS England that by the end of 2019-20 that the CCG will have reduced its management costs by 20%, including the costs of the board. The NHS plan clearly makes reference to the fact that it will expect to see a single strategic commissioner at each STP footprint level, and so that will require us to have some discussions with Telford about how we do that between the two CCGs going forward. And I would expect the board to receive some proposals as the options for doing that over coming meetings. I'm very happy to take any questions.
Any questions from the board members? In terms of the cost savings, is there a timeline where we're expected to achieve those?
The 20% reduction is has to be delivered in full from 2021. So we have the forthcoming financial year 19-20 to enact the changes that are required so that in 2021 that reduction is observed in full.
And our current spend within our running costs, we're currently above our running costs spend, so does that have a greater impact for us then as a CCG than if we're actually on target?
It does. The reduction is against plan rather than what we're actually spending. Now there is an element for our CCG in particular where we are still spending money on interims, whereby we've already got a plan in place to bring that down anyway. So what we'll need to do is assess our underlying position in terms of our substantive position. But just to give a sense of context, the target savings we're looking for based on comparison to plan is in the region of £1.3 million, so it is significant.
And when do we expect to have something to bring back to the board around a plan about that? And also a plan around what's in the long-term plan around the idea of a single CCG for each sort of STP. Do we have a...
Well, it actually requires you to have a single strategic commissioning voice. That doesn't necessarily mean a single CCG, so the options to do that need to be worked through with Telford. But certainly I would expect the board to expect an update in March.
March, okay, thank you. Any questions from anyone else on the board with regards to that? No? If not, we then move on to an update on Shropshire Care Closer to Home from Julie Davis. Lisa Wicks.
Lisa's here to...
Thank you.
Is that the microphone?
Broken it already. Thank you. Thank you, Chair. So give an update on the Shropshire Care Closer to Home, which is contained within the papers. Since writing the report, I'm pleased to confirm that the joint needs assessment has been received, and we're working closely with colleagues now to look at how that might change the needs, particularly around our community bed provision in terms of what our demographics are looking like now, 5 years, 10 years, to ensure that our plans are robust and sustainable for our community. We held our first pilot implementation group last week with providers to look at how we operationalise our case management and risk stratification, which is phase 2 of the programme, and we've got another meeting next week to be able to look at that more in pace around 2 sites, urban, and 2 sites that are rural, for us to be able to look at the control of that testing and bring those back into the design. We've set up a dedicated group to look at our comms and engagement, and once we've been through the next set of design around our step up, our rapid response, our crisis services, we'll take those design models out again to our patients and users and our wider stakeholders. Lots of the models in terms of that have been shared to date with the working group and actually with the programme board have received good detailed feedback around actually, yes, these models are robust and actually these do meet the needs of our population going forward. And we're now detailing those in terms of outcomes to be able to commission those. We have detailed service specifications that have been developed as part of those models that include the changes that will be required, the key performance indicators, and how we can potentially contractualise those models. The use of the additional primary care resources as part of our design group has really enabled us to work more at pace, to have that sense check in terms of how do we move this forward to support the primary care agenda, and we're aligning that very much with the primary care network piece of work that's taking place. We've taken at the programme board to look at IT and to use some additional resources in terms of Michael Whitworth to look at how we address the IT requirements of the programme at pace so that our pilot sites are able to have access to data sharing and a robust IT solution. I'm happy to take questions.
Jess?
Yeah, I think I just wanted to follow up. I've got a dodgy one here as well. I think I just wanted to follow up on what you've said by kind of drawing a couple of extra bits out, which in part relate to the long-term plan and the fact that what's described in the long-term plan in terms of an expanded community offer at locality level, supporting people in their homes and around GP practices is precisely what is envisaged in phases 2 and 3 of Care Close to Home. I think the other thing that I just want to draw out is as Finola said very recently in a different meeting to a different group of people, this is not in and of itself radical. We shouldn't, although this is a massive piece of work, this is up and running elsewhere. Where Lisa's had this up and running in Stafford, they're delivering actually very impressive admission avoidance, 10 times the magnitude that we need to achieve here in order to deliver Future Fit. There is no reason to doubt that this will support patients in their home. There is no reason to doubt that this will support the wider system work. It is completely aligned with the national trend. And the final thing to say is simply that when we had the additional primary care resource come in to the group, that was on the back of a lot of disquiet within primary care about what this represents, what it might mean for them, and where the flaws may be. There's a lot of challenge coming in, but there's a lot of support coming in as well from those primary care physicians. They really consider that the specs that we've presented, whilst in their very rough draft form, do represent an improvement in patient care and an expansion of community services that is absolutely necessary. So I think it's worth just highlighting that, because whilst there may be doubters and we need to make sure we are laying everything out clearly, as I said before, this is not radical. It does work. It's evidence to work in other areas of the country, and we need to crack on and get this done. Our population actually do need it.
Vanessa.
Of course.
But we've got Vanessa, then Graham, and then Julie.
I really welcome the comms engagement team that you've established, but can we be assured that in any work with the public, they will collaborate with the Council and the Healthy Lives Initiative that are serving the same areas? I'm really concerned that there's been so much consultation with various groups, and it's really not helpful to keep going back to the same population.
Yes, Jess.
So, Healthy Lives, I mean, Kevin Lewis and Penny Basin attend the programme board. So we had a presentation last time on PAMS, and a lot of the stuff that they're doing, they're actually part of it. They're very much part of the partnership that's delivering this work. So it's not a matter of simply reporting to them. We're working together to bring it all. In one of our previous board meeting papers, we actually gave the diagram of the pyramid.
Yeah.
And they're doing this bit. We're hoping to do this bit. The acute trusts do the kind of right at the top. But it doesn't work without those layers talking to each other. The programme board absolutely has those layers talking to each other. They're part of it.
Graham, and then Julie.
Yeah, a couple of areas, if I might. I was a member of this team initially for quite a while, and without a doubt is probably the best planned strategic project I've worked on for a long time. Parts 1 and 2 went through fairly easily, I would say, but for part 3, it was emphatic that in order for this to be successful, we must have an alliance. Now, it must be 5 or 6 months since the alliance started, and we brought in an extremely experienced consultant to help this. It still isn't there. Now, for part 3 to be really successful, to go along without an alliance, I think, is not the thing to do when we're looking at what happens in the next 20 years. But can you give me some assurance why we haven't got an alliance in place, and is it likely to be there before we get deep into part 3?
Julie, do you want to answer that?
At the programme board in December, the draft alliance agreement was taken and was agreed in principle by all parties, including the CCG, the local authority and the community trust. The local authority required some minor changes to the words. We are expecting that draft back this week. When we've got that, there's no reason why we believe that will be acceptable to both the CCG and the local authority. So I am hopeful that we will have at least one, if not 2 partners signed up within the next couple of weeks, and then that will be left with the community trust. So I'm as confident as I have been so far that we will have that arrangement in place before the end of January. We need it not only for phase 3 actually, but in order to underpin the demonstrator sites for phase 2. But we are in the. It's been complex because it's the first time anything like that's been done here. But I'm confident that we will bring it to a conclusion quickly.
From what you've said there, by the end of this month, we're letting include the community trust.
Yes.
Okay, thank you.
Absolutely.
The second one is frailty, which was phase 2, which has been working very successfully.
Phase 1.
But,
Phase
sorry.
1's frailty. 1. Yes. Phase 1. Case management's number 2, frailty's number 1.
Frailty is number 1.
Yeah.
You're quite right. You see, I'm getting old. But my understanding is it only has funding until March. Can you confirm that funding is guaranteed after March to keep this running? And the second part of that, staffing I know has been an issue with people moving around. Are we confident that we can maintain the success we had in the first few months of it?
Simon.
So it will continue in March. What's going on is a disagreement with SATH about funding and price. That's the only thing.
It is also in the long-term plan.
But it will continue. And of course, in the long-term plan, all trusts, all acute trusts are expected to have a frailty front door or unit.
Okay.
The staffing is in part related to the uncertainty about cost, price and funding, and we're confident it will go from strength to strength, because rather than operating 9 to 5 at one site, we would have it operating at both sites over a much longer period of time. Subject to being, but of course we need more geriatricians to do that.
I'm confident in it, and the reason I ask is we've attempted this over the last 5 or 6 years, and it suddenly reaches a stage where there's either no funding or it goes. So if there's an assurance it continues, that's excellent.
Okay, Julie, do you have a question or a comment? Or?
I'm conscious that there's not only from the questions from the members of the public, but also there's considerable anxiety around the tie-up between community beds and phase 3. And I just wanted to state the position in terms of for the governing body, that what the Joint Strategic Needs Assessment does is it enables us to model our population not only from a demographic point of view but from a disease prevalence and where we see long-term conditions like dementia going over the next 5 to 10 years. What we needed that information for was for us to enable us to model what that demand looks like, because we've had fixed term numbers of community beds that just do pathway to bed-based rehabilitation. The future, anywhere else in the country, those rehabilitation beds, A, tend to be much more flexible, and they also have numbers that are specifically assigned to more specialist rehabilitation, so things like neuro rehabilitation, post-stroke rehabilitation, and also for patients with dementia. So I absolutely assure the governing body that the work we will do in phase 3 will ensure that our rehab bed capacity will not only meet the needs of our population, it will also meet the specialist needs for those expectations in terms of how those needs are going to change over 5 to 10 years. And also the fact that we need that capacity to be flexible, and also the geographical nature of those beds. We need to have the beds available for the demand in the north, the demand in the centre of the county, and the demand in the south. And currently, that's not equitable. So all of that modelling and how that is going to be done will absolutely come through this governing body and will be available for public scrutiny. Of course.
Okay.
There is absolutely through care close to home. I'm sorry, I take objection to that. There absolutely is in the care closer to home.
Just we're not responding to questions to the public, so.
Okay, I'm taking over. I'm still nominally deputy chair until he decides that somebody else is, and he's left the room. So, Meredith, you had your hand up.
Thank you. Yeah. First of all, I just wanted to say thank you to Lisa and to the small team, Barry and Laura, for doing an enormous amount of work. Honestly, the industry that's coming from them is quite incredible. So I want to say well done, thank you very much, from my perspective at least, and I hope the board would support me.
Thank you.
Secondly, Graham did play a very important part on the programme board, so I'd like to recognise his contribution as well as a patient representative. And finally, because Graham's left, there is now a vacancy for a patient representative on the programme board, and an invitation to apply to be a representative on the board from the patient perspective is, I think, gone active today. It's either today or tomorrow, so people will be able to apply to fulfil that role.
That's good. I'm sorry I had to disappear. I had a bit of a family emergency, but it's all fine. Bad night out, apparently. John.
Thanks, Lisa. You've mentioned the focus on IT, which is just a general question around that in terms of the level of development and progress with the IT for this service and the confidence in delivering the IT that's required for this big piece of work.
I think, as Jess said earlier, what we're trying to do isn't unique, it's not innovative, and IT solutions have been tested and used in other areas to enable us to have a shared record for providers to be able to access information. So we know that there are particular products out there that allow systems to talk to one another, and that some of those cost more than others. There is development within and records and other health economies that we can learn from that are not vastly expensive. We've outlined our requirements through the IT group for the pilot sites in terms of we need to have a shared record that everybody can access, and we need to enable IT systems to talk to one another. Ideally, that would have been developed through the STP group, but we've taken the decision through our programme governance to have a dedicated group that's made up of all the provider IT leads who are looking at how they can deliver that, what the cost of that will be. And because that hasn't been moving at pace at the last programme board, Dr. Freeman took that challenge on himself to be able to drive that forward on our behalf.
Simon, do you want to respond to that?
Just, we don't want to get stuck in the thing that everything is dependent on IT, though.
Wasn't the suggestion?
Because not all of it is dependent on IT, but that IT, you can do different things with IT that you can't do without it.
And significant events often come out as a result of IT inadequacies. So.
Yes.
Any further? William.
Thank you, Chair. This obviously is one of our key programs for the CCG, and I put it on the same footing as Future Fit, I think, in terms of, and it's great to see the level of resourcing, I think, is starting to reflect the complexity because of the number of partners involved to implement it. I guess the question is, because we're very reliant on our providers to effectively change the way they operate, to implement some of the solutions in care closer to home, and given there are other pressures at the moment, are we getting the level of engagement that we feel we need? And is there anything else we need to do to sort of encourage them to become more engaged, if necessary?
We've always been fortunate that through the governance of the programme we've had good representation actually in the design phases through the task and finish groups, but also through the working group and the programme board. At a previous meeting we talked about the bulk of work was still sat very much with CCG colleagues, but since then Shropshire Community have provided some additional resources around strategic comms as an example for the programme, but conversations are still ongoing around actually how do we work more collaboratively, and I think that really came to pass last week in the pilot implementation group where all providers actually did divvy up the actions and work collaboratively around how we can operationalise those. I think, again, the work there rests very much on the delivery of the alliance agreement to enable us to contractualise that. And through those outcomes, the pressures of their day-to-day job and the outcomes of this programme should be very much aligned. And we have tried to align the transformation programme with other providers' priorities as well. But I think if we can get the alliance agreement signed, continue to work in the way that we are, the ask has been there and people have responded and attended, and we're very grateful. And Meredith mentioned the work that we're doing, but actually the comments coming back critiquing our work are coming through as well, and so it is really a team approach. So I feel quite happy with that level of engagement.
Keith.
Just to go back to Graham's comments about the alliance agreements and what Lisa's just been saying, it does sound really central to getting some of the improvements bedded in. And I do share Graham's concern that some of this has been going on for months. And I just wanted to be clear, if this isn't resolved by the end of January, as Julie was outlining, what action would be taken to make sure that this is resolved? Because
that was going to be my final question. Was I think that this work is really good. There's a lot of energy, a lot of effort, and it's good. There's collaboration, but don't take this the wrong way. But the reports don't seem to move on much each month. We're still waiting for the alliance agreement to be signed. We're still waiting for pilots to be in place. And my question was going to be, what happens in February if we haven't got an alliance signed and if we haven't got pilot sites actually on the ground and working? And so it does tie in with Keith and Graham and some of the other comments as well. So
we had quite a lengthy session yesterday around all of our QIP schemes, not least this being one of the largest in terms of transformation. And we agreed out of that all of the key senior people that are involved in the project are going to have a meeting early next week to basically line up all of the key steps that we need over the next 2 weeks to make sure that happens. and to ensure that we've got an appropriate plan B. So I'm confident that, you know, by the time we, certainly in terms of, I know we don't have a governing body in mind, but certainly in terms of the subcommittees for clinical commissioning committee, then we will be able to advise of what, you know, as well as hopefully making the progress in plan A that we will have as a CCG, because we know that it's too important. Our system cannot allow us not to do this. And the other thing that will also support us in helping to get a greater pace of traction, I believe, is that we're also in close discussions with our colleagues in Telford and Wrekin. So I'm also confident that over the next few weeks and months, actually, this will become an STP-wide project. And then, whereas in the past, sometimes providers have quite rightly have felt challenged by the fact that there's potentially been a different approach across the two commissioners, I think by bringing that together and having a single approach, again, it removes another obstacle and puts us in a much stronger position to get this model of care. Because as Jess said, it is not unique. The way we may have to deliver it might be a variation for Shropshire, but this is a nationally proven model of care. It's in the long-term plan. Everything is aligned. There is no way that we cannot move forward on this.
Because reflecting back on Lisa's comments about wanting to have elements of this contractualised, we've got obviously a very strict timeline to sign contracts off, and then that's it for 2 years. So I wouldn't want any delay to hinder our progress on this.
It's a key part of those. Again, it was mentioned yesterday. It's a key part of our contract negotiation
do you want to
strategy.
come back on that for 1 minute?
So I think, irrespective of the national timeline, we won't be signing anything off until it's the right thing to sign off.
Right, okay.
Thank you. Any further questions? Otherwise, thank you for that. It's very positive, and I think it is moving forward. It's just that I always like things done yesterday.
Appreciate that.
But so we're asked just to note the progress of the programme and note the next steps identified. So thank you very much.
Chair. Thank you.
Thank you. The next paper is also Julie and her team, which is Steve Trenchard with the BU 0 to 25, which again, I remember 4 or 5 years ago when we first suggested a 0 to 25-year-old service, the MPFT or whatever it's called at the time sent us away with a flea in our ear and told us 0 to 25 wasn't the right direction, but it seems to be in the long-term plan now, so I guess it was.
It must be true.
Must be true. So Steve, thank you.
Thank you very much. Happy New Year, everybody. So I'd like to talk to you about an update in relation to the BU service. Very brief paper, and in the summary I talk about being able to provide you further verbal information, particularly around the completion of the clinic's physical health reviews for those children that were identified as red, of which there was 32% of 715 children. You'll recall, I'm sure, in detail from a previous report. I can now confirm that all clinics have been held by MPFT for those children, and also that there were no concerns about the physical health of children following those assessments. I know that was a particular concern of the board. That meant that we escalated that risk, that issue to the BGAF. The ongoing nature of physical health checks are now embedded into pathways, and MPFT have appointed a phlebotomist who will be able to undertake the appropriate checks with those identified who are on medication. There are some other things I'd like to report on, though, in relation to the service. So in particular, waiting times. Waiting times have been a concern of the board, I think, since the service was decommissioned and prior to that. I can report that significant work has been undertaken to reduce waiting times. And the total number of children on the waiting list has reduced from 1,964 to 628. Data cleansing continues. And that's given us better data, better quality data in relation to that whole process. The average mean wait for treatment has dropped from 151 days to 92 over the past 11 months, which is good. And that's something that we should be pleased about. However, it's still too long. And we are given that message very clearly in our contractual meetings with MPFT. So whilst there has been improvements in relation to children on waiting list, there is still work to be done. In relation to the children who move on from the service and who are discharged and who recover from services, I just want to take us back to the IST report that was presented here in October. I think it was the first time I came and gave a report. In May, when the IST, the Intensive Support Team from NHSI visited, the number of 1,475 children on the medical caseloads was referred to. We've subsequently asked to see that hard data, and there is no hard data at that time. That was a number that was given verbally in their interviews with staff from MPFT. You'll recall that what followed was a number of conversations between commissioners and MPFT and the requirement for them to do a more detailed audit into the current caseload at the time. And I can give a little bit more information on that now. So in October, the audit that was carried out in September and October identified that there were 1,234 children on medical caseloads. And of those, 715 were on prescriptions, which was 58% of the medical caseload. On average, we're seeing 60 children being discharged a month from consultant caseloads. And so over a period of 6 months, we'd expect 360 children to be discharged from services. What I'm pleased to say is that we are seeing just over 350 children being referred into services. So over time, we will see a drop in service. So the flow seems about right, which is good news because it means that the service is not over capacity and the service is demonstrating the ability to respond to the requirement to do transformation and create the new pathways that were originally commissioned. So the service does seem to be in a better place in relation to that flow of people through services. I guess the final thing to say is that, just to summarise again from the original paper, is that so significant work has been undertaken. We now have assurance from both the MPFT audit and our own independent audit from pharmacy colleagues, and from the completion of the clinical reviews, that the children identified in the red group who were on medication, that there's no harm. So there's been no reports under the duty of candor, there's been no harm identified. We are confident that prescribing for children and young people is reviewed on an individual basis. That was identified both through the 2 audits, and in fact our internal audit from the CCG gave us a very clear message that the MPFT audit and their assessment of the caseload was very cautious. So they kept to the strict line of NICE guidance and appropriate other guidance for understanding both the pharmacological interventions and also the pathways that you'd expect, which is positive. But we still have concerns about the waiting time for children and young people coming into services, and that's something that we will continue with. What sits behind all this work is a very clear action plan. The action plan has gone to NHSE. There is a clear process in place now for the governance around that action plan. From this month onwards, I'll be providing a more detailed report to the executive team around those assurance actions that include both the individual things, as we've seen, and the service pathways and the interventions, as well as the things we'd expect to see across the system.
So can I just ask some clarification on some of these figures? Yeah. You said the average mean wait's gone down from 151 days to 92. What are we currently aiming for and what's in the contract? And what's the actual longest wait? Because obviously it's the longest wait that's important. And just the third point about the numbers was, did you say that so 360 people have been discharged in the last 6 months, but 450 referred in, or did you say?
So I'll deal with each of those.
Yeah.
Because I'm aware there's a lot of information. And I will circulate the
It's really good to have data, but the more data you give, the more
questions you're going to ask. Yeah. And I will provide a detailed update for the minute as well, so you got that. So in relation to the longest wait has in fact increased from 192 days to 598 days.
That seems a long time.
That's the single longest wait.
Surely presumably that person's been contacted and assessed, and there's
I understand so, yes. So
yeah.
that's clearly that is a concern. But the overall, the mean weight has reduced. So the weight across the full caseload has reduced.
If you take out that 590-day weight, what's the mean? Does that affect the mean? Because presumably that's enough of a weight to actually put the mean up, you would have thought.
It would do, but I haven't done that calculation, so I'd need the full data set to do that.
And is that a very long tail? Because obviously one person waiting 5, there may be very specific reasons, and I won't want to go into any of those now, but you know, that's, you know, if they wait any longer, they won't be in the 0 to 25.
You know, since the longest wait was 192 days.
It was.
It
It's increased from 192 days to 598.
That wasn't 306 days ago that we reported that, though, was it? So I don't quite understand that. Do you see what I mean?
Yeah, where'd they come from?
So these figures are based on, so we asked, as part of our contract process, we asked for some very specific figures on the current caseload from MPFT, so these have just come through this week. So this is a highlight report from those figures. I think there's more work to be done. The information that we've got gives us further limited assurance, but there's more information that we still need to fully understand. Absolutely.
About data quality, which is a reasonable point of Simon's, that if this person 6 months ago wouldn't have been 190 days, would they? But yeah, and then what must be aiming for in the contract?
I think the point is, the point you're raising is actually, it's not just mean is always can be helpful, but equally it can disguise a whole multitude of sins. It's actually the shape of the waiting list that's important. So I think it's something that I'll take back with Stephen. We'll work with that to get that more of that shape, so that we know not only the longest wait, it's exactly the same in all sorts of other measures. That longest is a critical indicator, but also the volume and the reasons why. So I think a shape of that will be helpful.
I think what we will develop by the end of March, when all the pathways are done, for each of the pathways and specialities that we wish to see, is a very clear sense of what's the capacity and the flow and the demand for those services, and what's your ability in terms of workforce to meet the needs of those particular groups of children. At the moment, we don't have that in any detail as yet. That's work to be done over the next 3 months. At the front end, in terms of waiting times and in terms of early help, what we do know is that there are approximately 800 children and young people that access beam drop-in sessions on a monthly basis, which wasn't in place beforehand, and that on average 200 children and young people are registered for support online for COOTH, which again wasn't there. So I think there are things to feel good about in relation to the service, but there are still things that we do need to dig into more with the...
I've got a number of questions. 350, not 450. It was 360 off and 350 going on.
That makes more sense. So I've got a few people already. There's Rod, Mike, Matty, Jess, and then Matthew Bird. So if we start with Rod, then Matthew, then Mike, and then Jess.
Thanks, Steve. The last set of figures that you gave partially answered the questions that I was going to highlight, which was around things like COOTH and how parents and young people themselves were accessing early help services. At the other end of the spectrum, I'd like to get an understanding of those urgent cases and how they've been dealing with, because in previous presentations to the board we'd highlighted that for those children and families where there was an acute need, there had been problems in the past. So what's the assessment of those cases telling us now?
So if we do, so we know there's generally a positive picture for more routine sort of common mental health problems and distress that arises in young people. There's easier ways of getting that. The caveat to that, I'd say, is that it's still very Shrewsbury specific. So there is feedback that we need to do more on the edges of the county and to think about that. And that's either down to poor access to connectivity, so you can't make use of the online stuff, or just the physicality of not being able to access services that are only here and at certain times of the day. So I think we need to understand that a bit more and think about what that means in terms of commissioning. For urgent cases, there's a couple of ways into the services. There's ways in through the access team. I think there was confusion for GP colleagues about how to access and having different numbers. There's now one number to contact for an all-age access team. The access team are providing additional training, support and supervision over the next couple of months for practitioners working in the access service, so that they're able to address distress. And the model is shifting away from an assessment and a conversation based on a diagnosis to an assessment based on distress and meeting needs associated with distress rather than providing something that's diagnostically led. So that's part of the purposeful change in the culture, to shift that model away from an over-medicalisation of what often is normal distress in young people. We had some feedback in the system review for young people who were turning up at A&E in particular, and those from looked after children cohort, and particularly where there was some failure or breakdown in foster care arrangements, and then people turning up in A&E, young people turning up in A&E who are more likely and more prevalent to be self-harming. Additional monies has been provided for winter pressures, and we have extended the opening hours of A&E, already to 24-hour for this part of the patch, but the patch over at Telford and Wrekin has been increased. Personally, I think that was a bit of a disappointment. I was disappointed by that allocation of money. It's great to get extra money. I think there is something that we could target more specifically in a collaboration with local authority colleagues to focus on looked after children before they get to A&E, and that's something that we're in a conversation about. So that is an identified need that we need to address.
Okay. Matthew, and then Mike.
You told us that 750 of the children were having prescriptions of the 1,234 on the medical caseload.
Yes.
How does that compare to sort of national averages?
Off the top of my head, I couldn't say, but I can find that out and bring it back for you. What I can say, though, is that in relation to in an internal benchmarking against the whole of MPFT services and other children's services in Staffordshire and the north, we would double the amount of medication usage than their services. So the use of medication in this service was very high. And I think that was already known, which was, it might not have been known factually, but it was known in terms of the process that led up to the decommissioning of the services, which was that it was predominantly a medication-based model.
And that was raised at our South Locality meeting. Did that reflect an individual clinician or lack of availability of talking therapy and further support, that it's easier to do a prescription type situation?
It was, I think it was a mix of a number of things. So it was in part down to some clinicians, who I understand have since moved on, and it was in part down to a lack of any choice. So it was a predominantly medical-led service, and the medics were locum medics who are more likely to be risk-averse and who are more likely to prescribe medication. This is why there's a shift towards, and there's already been an allocation of a family therapist and clinical psychologist, rather than replace medics like for like. What we haven't yet got, which we're asking for, is a very detailed breakdown of the workforce, both existing and future, to deliver a new model. We expect to have that by the end of March, so that we can see that the staffing profile reflects a more balanced psychosocial approach rather than a pure biological approach.
Thank you. The last point on that at the South Locality that was raised was that it was the perception amongst us that you might not be aware of quite a lot of prescriptions being done for this group, that as GPs we're being asked to do, and we weren't clear how you were able to measure that amongst this 750, so it might be a bigger number.
Yeah. So there is a separate piece of work which is ongoing at the moment with pharmacy colleagues to identify that additional cohort. Because we don't have the same sort of access into IT patient systems than they do at Telford and Wrekin, it's going to take us slightly longer to get that information. So that's underway.
Thank you. Mike, then Jess.
A couple of quick things. Firstly, drop-in centres, no use to Market Drayton or Whitchurch or Ludlow because they can't get there. So I'm glad Bob brought it up, because it's a waste of sending a standardised letter to us. Secondly, there's two other issues which have been brought up. Looked after children, especially with CAM's needs, still remains very poor transfer in or out between the two local services. I have to say that CAM's here, actually, I can actually praise them, and it's actually some of the services coming, but there still needs to be a lot of work about other CAM services around the country. Finally is 18-year-olds. There still seems to be ongoing issues about it's 18 to 25, 0 to 25. There is issues of concern, especially when children get to around 16, as to what service they remain in. And some people, even in your service, don't seem to know what the rules are, because we seem to have had disagreements. People saying, I'm scared I'm going to be kicked out without continuation of care, and that's one of our concerns is brought up, with people just being discharged because they are now getting close to being 17, 18, and therefore they can be discharged from the service, and that then leads us to having to refer them back in, which has led to a lot of distress with some of the children because they had the continuation of the service. So I don't know if that's actually helping or that's just other issues that are bringing up. But
okay. No, I think it's important to get the feedback.
But
I mean,
that is important, and the looked after children, we have had quite a few problems of people coming in from out of area without any records of what's gone on. Some people quite complex histories, and it's not just me, it's a few people have had issues, and it's caused quite a lot.
I think we've been doing a lot of work around the looked after children, because it has been a problem that's been highlighted quite widely.
That's what I thought we had, and that's why I was bringing it up.
No, it's important to bring up, but I think we have improved things. There's still issues, I think, but I would encourage any GP or anyone who's referring someone in with a problem just to come to us if there is a problem. Come to Steve, who's our commissioner, and he can liaise with the provider.
I think, like I say, I'm actually for once I'm not saying it's CAMS this time. But it's trying to work on a national how you can get a national policy for transfer records in when they move.
Jess.
Yeah, relatively quickly actually. You described the wait for treatment. Is that distinct from the wait for assessment? And if so, what is the wait for assessment? And also, a lot of the concern we had right at the beginning was around access to assessment, access to services, the fact that we asked for a single point of access front door, which would signpost where appropriate, and they weren't really doing that. What kind of progress have we got there?
So I think that there's been progress on the front door. There's actually a meeting now on an update on how that's been going over the last 4 weeks over the Christmas period. So I can't give you the penultimate update. In terms of waiting times for treatment, I'd need to check exactly what the spec says, but my expectation it'd be within the normal national 18-week wait, but we'd need to check on that one. For assessment, there's very clearly a graded profile as part of the assessment. The access team, which is, if it's urgent, it should be within the day. If it's routine, it should be within 72 hours. And that's the working model, which I've seen the SOP for. I know there's some surprised looks. The feedback is often it takes longer than that, but that's what they're working to. So we can pick that up and ensure that we've got. I mean, I think one of the things that we are in the process of doing as well is actually is trying to be smarter with the data that comes through in relation to showing the data through the PAP. So what I would expect to see through our contractor meeting will be a very clear, this is the number, this is the, starting from the JSNA, this is the expected prevalence, this is the number coming in, this is the number been assessed within time, this is the number through pathways, this is the treatment success through pathways. We are some way off that, I have to be clear. I think we'll get there, but we're some way off it.
Okay, thank you. Sam, one final question, I think, from you.
It's just a slight aside, but I wonder whether this gives us any cause for concern in relation to an over-reliance on medication-only interventions for adults provided through the same organisation.
I think there is a national concern on the medicalisation of any mental health condition. The adult pathways have been revised, or the adult service and community service has been revised into pathways. Interestingly, the long-term plan does talk about place-based integrated mental and physical healthcare pathways. I think what's interesting for our local provider is that there are pathways that are offered in Shropshire, and in Staffordshire there are integrated teams that they're further on with. So my sense is that we would move back towards a much more clearer integrated team model at place than pathways that feel more distant. And feedback that's already coming up from GP colleagues is that the current model feels less relationally safe. the access to consultants that they've known for a long time, particularly over some complex individuals, is less so. And actually, if you aren't engaged in the local, then the whole notion of recovery, which is all about how you get on with your life at source in the community of your choice, is sort of missed. Okay. So I think there's work to be done on that in terms of the mental health strategy.
Thank you for that update. Sorry, Meredith.
Thank you, Chair. Thanks, Steve. Very helpful and informative. I'm always a bit uncomfortable when we spend lots of time talking about times and numbers, access points and so forth, because that doesn't tell us anything about how good the service is. So you've been with us for a few months, and I just want, it's an open question, okay. Do you feel that our arrangements...
Not leading me at all.
No. Do you feel our arrangements that we have in place to review and consider the quality of service are robust enough?
No.
And my second question is, what do you think we need to do more of, and indeed how? Two questions. Sorry.
We've had this conversation that I've sat at the clinical quality CQRM meeting, 3 of those now, and each one I've said I'm not really quite sure what the information in front of me has told me about the quality of the services that we provide, or that you provide, and we commission. So what we've agreed is that we would have a forward plan on all the service elements, so that we would invite people, clinicians, practitioners and clinicians, and also people who are receiving services into that meeting to do, not to duplicate what the role of the trust is around their quality, but for us to get assurance on the quality of those services. I think we also need to understand and to move towards a model that commissions outcomes. So interesting work was done back in 2017, where MPFT, as part of a sequin, were asked to deliver outcome-based, to use outcomes, but there's been no update since that time. So we've got no sense of where that's up to, how it's gone, whether they've been routinized, etc. I have seen evidence that for each of the pathways, there are dedicated outcome measures that will be good, they're validated, they're tried and tested as outcome measures, that include things like the friend and family, but they're a bit are more sophisticated. You know, some of those have been developed in conjunction with co-produced with service users and carers and validated through clinical trials, etc. So they're good outcome measures, but there's no, they don't come into the contracting process or the quality process. The quality process tends to be retrospective. So in terms of effectiveness, patient experience, and incident and safety, we get the same information that the trust does on safety and incidents, etc. So everything's clear. I think we just need to ask for different things. Okay. We're not getting enough on quality and patient experience.
Thank you. We've obviously got the quality report later on, so thank you for that. We've noted the contents of the report, so thank you for that. And we'll probably get an update back for the next board meeting, public board meeting in March. That'll be good. So we now move on to one more paper before the break, which is transforming maternity care, and that's Jess is going to do that update in Dawn's absence.
Yes, so this is a very brief update following on from the report that came to the governing body in November 2018, where we set out the anticipated timeline for delivery of this programme of work. And since then, we've been able to allocate a dedicated resource to taking this forward. Fiona, who's been leading this piece of work for us, was being pulled in all different directions and really needed her time freeing up to be able to do this properly. So we've been able to manage to resource that and get additional support and advice in with appropriate expertise to take it forward through the assurance process. We've got weekly progress meetings now in place. The last stakeholder workshop that we held a little while ago, some members of the public were there, I can't remember exactly when it was, a few months, gave some very important feedback that has been acted on and will be further developed and reflected upon in another workshop, which is going to be within a month, I think, from now. And then following that, we should be able to present finalised plans and take things through the last part of the assurance process.
Okay. Any questions? Simon.
So this is a pretty poor paper, isn't it, for a board? So that won't happen again, but don't quite know how that got on here. Just so members of the public are aware, this consultation will not commence prior to the conclusion of the Telford and Wrekin Council elections in early May due to the need to observe PERDA. So the consultation won't commence until after that date.
Any questions from the board with regards to that? Meredith.
Thank you very much. The transformation that Jess, you and Fiona have been working on, like Shropshire Care Close at Home, it very much involves our system-wide partners, particularly around social care and the mental health provision and so forth. And I just wanted to get kind of your sense of whether all our partners are fully involved in this programme of work. Or, and the reason I ask is it feels to me like it's kind of the CCG doing all the work with not much input from others. I might be completely wrong. Can you reassure me?
Yeah, I think it continues to be a collaborative piece of work. SAF, as the current provider, have obviously been very important in giving us detail around the issues they're facing at the moment, the facts and figures, and verifying some data for us. We've had expertise from outside of the system. The mental health side of it, the public health side of it, members of organisations that manage those services attended workshops and continue to attend workshops, but they also discuss this work on a regular basis through the LMS. As we've discussed before, this is a stream within the LMS. It's not run by them because it's a service review prompted by service pressures, but nevertheless, because it fits within that wider piece of transformation, they do have oversight, they do discuss it there. So I think all partners are fully aware. There's a natural hiatus where we go through the assurance process, and then I think everybody gets involved again when we get towards implementation.
Thank you.
Thank you. Any further questions? If not, we're asked to note the contents of that report. We now have a break. There's some fresh water for coffee at the back, and if we can start again at 25 to 3. Thank you. Thank you. If we could take our seats to start in a minute or so.
What's plan B?
Did he buy the first 6 books and the field books? From we released. James Stewart had all these hobbies. James David Blackini saying that they shot. No. Thank you. If we can start again with the CC Administration Resources paper, we didn't do because it was covered by Claire when we talked about the 20% efficiency or the 20% saving and running costs. So if we move straight on to paper 13, which is the Finance and Contracting Report.
Thank you. So the report here that we have today is our month 8 position, which takes us to the end of November last year. We continue to report that we have a fully mitigated risk position. However, what you'll see from the narrative in here is a flag really in terms of the concerns that I have about that position as we move closer to year end. We don't have within the report any significant material movements in the position itself. However, the team did a lot of work with our managers in the preparation of this position, actually looking at our risk assessment and the likelihood of being able to land some of the assumptions that are in here. As the report highlights, we think that there is a risk within this position that we're reporting of around about £3 million. And that's on the basis that we have a ticking clock. As every day passes, that's one day less as opportunity to actually physically cash out any savings that we might require to meet that position. I think in terms of highlights from this report, we have now incorporated the additional £4 million support that NHS England confirmed to us. And I think that's important to note in terms of my ongoing flag really to the governing body in terms of our underlying recurrent position. So as we've talked about previously, even if we were to land the position this year and land our control total target, we still have a number of non-recurring means that we've deployed to do that won't be available to us next year, and so it just makes the ask for future years harder because we've still got to recurrently get ourselves back into balance. In terms of our contract position, we have made a year-end deal with SAF. That's now fully crystallised into the position and means that there's no risk of volatility around that number, which is great for both us and the trust actually, because the numbers won't move again, and that's quite a significant part of our expenditure that's fixed down there. We're continuing to have conversations with Robert Jones. We haven't agreed a year-end deal with the trust there, but we are continuing our discussions about their performance financially as well as in sort of activity terms, and we'll play that through the position as it goes. As the report highlights, we have a number of contract performance and activity query notices open with a number of our providers, and again our usual process is picking those up and we're pursuing them. And just really to give some assurance, we may well have landed a cash deal, a finance deal as it were with SAF, but we are still monitoring them on any of our open queries or notices, and we'll make sure that we close those down irrespective of the fact that the numbers won't change this year, but it will have an impact obviously as we roll forward into the new year contract. Just as an update on a couple of items within the report, I know we left it quite open here because we hadn't had any feedback from the meeting, but certainly one of the areas of discussion last week at our Finance Committee was around West Midlands Ambulance Service and what intelligence we were getting back about the overperformance there, because that's pretty significant really. Year-to-date overperformance of 7% against plan. We are still not satisfied with the responses that we've had back from the most recent contract meetings. And I've asked for more updates to come back to Finance Committee. Julie, do you want to?
We discussed it at the A&E delivery group last night, and what we took there was a draft terms of reference that we're going to have a local group that focuses singularly on ambulance demand and alternative pathways.
Brilliant.
We are conscious and mindful of the different dispositions as a result of the national 111 algorithms, and we're aware that we won't be able to influence that. Therefore, we've got to find a different way of working with that. We have got agreement from ambulance colleagues, and we got broad system support yesterday to attend that group. It's going to meet weekly in the first instance to get a grip of the data and to understand what's causing that underlying demand, and then there'll be a second phase that will meet fortnightly that will then work with clinical colleagues from the ambulance service, from both hospitals and from the CCGs to help us come up with those alternative pathways.
Thank you. And just another item to note before I pause and open up for questions really, is that we'd got within the report some outstanding information requests and a long open challenge really with the community trust. I just thought it was important to highlight to the board today that actually since this report was written, we have both received the outstanding information requests which the team are now looking at, and we have had confirmation of agreement to those challenges. So I just thought it was important to flag that there had been progress on those because they've been live in these reports for a number of months. I'll pause there and I'll open up for any questions or comments.
Thank you. Keith and William.
Thanks for that, Claire. At the discussion at the Finance Committee, certainly recognised the £3 million figure you're raising, and just to be clear to the governing body, there was concern about the impact of the backloading of the QIP figures into Q4, and that if there's an underachievement on that worse than the forecast, then the 3 million could be the lower end of the expectations for the risk to the control total. So without disputing the 3 million figure Claire quotes, there was concern about the amount of risk that we're carrying into Q4. The other point that you already raised, Claire, about the underlying run rate pressures, just to be clear, we've got to agree a budget in March, and we had an extended discussion last year agreeing our budget. Those underlying pressures are just a demonstrative example of where we're going to really struggle to agree a budget, because the pressure for next year's budget is immense. Yeah. So until we see something about any additional funding from the centre, that is going to be an immense pressure.
I think it's worth adding there, we're still waiting for the guidance relating to the financial rules and indeed the allocations to CCGs and what our control total might be. So we're building our plans, but until we get that part of the jigsaw puzzle, we can't complete that work.
Yeah. Simon.
Yeah, just all things being equal, clearly wouldn't be in a position to sign off a budget, would we?
But we have a hard deadline that we can't get beyond, whereas last year we delayed it until we agreed.
Yeah.
This year we can't do that.
No, but I guess what I'm saying is all things being equal, the ability of the CCG to hit, say, a 6 million control total next year would be quite ridiculous, wouldn't it?
It would be a challenge. Can I just go to my last 2 points, please, Julie?
Yes, sir.
Secondly, the answer on the West Midlands ambulance data query, just to emphasise some of the concern from the Finance Committee was not just whether the data is accurate or what the cause of the demand is, it's the fact that this has been raised with the West Midlands Regional Contract Lead, which is Sandwell, numerous times over a long period of time, and it's taken an eternity to get no response, and so we were extremely concerned about that. And then secondly, we were very concerned about Shropshire community not having the information about the out of hours stuff. It's a new contract that's coming on the 1st of October, and we still had no data. And the committee wanted to express back to Shropshire community our serious concern about why this data wasn't available, because it's a central part of us seeing what's happening with that important contract.
I think, can I just mention one thing? In the long-term plan, it mentions, I think, that they're planning to have a national framework for ambulance contracting, I think. One of the points it raised is the difference around the country in different ambulance contracts and the way they're managed and reported. So that, I think, would be a positive for us if there's a national contract, because we are disadvantaged both by having to pay a higher cost because we're rural, and also by the fact that it's the ambulance that are dispatched rather than the ones that arrive that we have to pay for. So I think that was another positive thing that was in the long-term plan. But Dave, do you want to answer the Keith's points?
I don't have anything to add to the points. That's what we discussed at the meeting.
Yeah, I've got William and then John.
Thank you, Chair. Claire, a question. It's become sort of normal practice to try to do a year-end deal with our main acute providers. I guess the question is, at the end of the year, after the year-end, do we actually ever look back and see whether that was actually a good thing to have done or not?
Yes, we continue to monitor the activity reports that come through from the Trust. So we will always have that comparison of, at year end anyway, once we've got that month 12 data, where did we land in comparison. And I think as well, because we're doing the baselining work for the contract for next year, we've almost got a secondary way of keeping an eye on that at this time of year, because we're running through some of that data as well. It's something that we normally do internally, but I can certainly put a note in the diary and we could incorporate that into reporting to the committee. It won't be till sort of the end of Q1 because of the data lag, but it's probably worth me bringing something back at that point. Yeah, I'll do that.
Because I was just wondering, overall there must be a net winner and loser of that early agreement of year-end position, and whether or not it works for or against us over the long time, or whether it varies year to year.
We'll have a look at that.
John.
So just a quick question on the ambulance activity. Is there any influence
from... Can you the microphone a bit?
Yeah, sorry, it's a quick question on the...
So I'm actually having problems hearing as well because of this fan. Is it possible to get that turned off? Because it's...
Just a question around the West Midlands ambulance service activity. Is there any influence on sort of 111 activity now that calls are taken by 111 rather directed by Shropdoc? Is there any evidence to say? I believe there's no evidence that there's an increased transfer of patients to hospital, but it's more around are there more ambulances being called out to patients' homes who are then not transferred.
There is increased conveyance as well.
Okay.
There is increase in conveyance, and there's more dispositions to the ambulance, whether or not they're being dispatched. That's how they go through their clinical triage. That's what we use in the group to understand.
Dispatch them now, Julie, then they have to go.
Sorry, it's difficult here when there's two people talking at once and not using the microphone. But so, did you want to add something, Gary?
No, I was just qualifying that if 111 dispatched to the ambulance service, they have to attend. It can't be overridden.
And is that the driver for this overperformance that we're seeing in the finance figures?
That's what we have in the group to understand, because there's lots of conflicting information at the moment. We want one single point so we can get to the bottom of it.
Okay. Simon, did you want to say something?
I just think it would be interesting to understand whether the ambulance service have had to deploy 7% more assets to meet the 7% increase in activity or cost. I think that would be a very interesting question for them to answer. If they haven't, I question why we're paying it at all.
Okay, thank you.
I also want to know what's happened to the time on scene.
Sorry, Gina, I can't hear you because use the microphone.
I want to find out about the time on scene, because one of the things I want to know year on year, as well as the conveyance rate. We know that it sometimes takes longer for an ambulance crew to stay with the patient and to keep them at home than it does to put them in the back of the ambulance and convey them to hospital. We've known over recent years that their time on scene has increased, and we know that in the winter, when they are under pressure to get the crews back out on the roads, absolutely, because the biggest risk is the patient waiting for the 999 response. But if that's reduced that time on scene, then that's also going to be causing us a problem. So it's all of that we've got to unpick and then come up with the alternatives.
We need to look at it in the wider mix, don't we? Because if conveyance is down but time on scene is up, then that's a positive. We need to look at everything in its totality.
Okay, thank you. Mike.
Sorry. There was issues before about Shropshire ambulances going to the Midlands. Is that still happening, or can we find out if that's happening?
There is no such thing as a Shropshire ambulance.
Oh, right. So, but the ambulances which tend to help in Shropshire, are they being diverted to Wolverhampton and the West Midlands?
They operate a rapid deployment model, Mike, which means the centres out of Shrewsbury and Telford are deployed to wherever they need to be, and if there's ambulances actively deployed in the north and south of the county, if they respond, then they get backfilled with other ambulances. So it's very hard to say. We know that historically, if anything, we're a kind of a net contributor potentially on the border with Wales. We also have a border with the Northwest Ambulance Service as well. So it's all hugely complicated. The important bit for us is that what's happening for our patients and making sure they're getting the best response that they can get, but equally that they're also getting the outcome in terms of whether they need to go to hospital or try to be treated at home or in the community.
In terms of the finance board, we're saying we've written to the regional commissioner, but we've not heard any response back. So
with the support of the regional commissioner, we raised an activity query notice because we wanted to get to the root of what was driving this percentage increase. We have now, through the usual contracting route and the contracting meetings, received a response from WMAS. However, that response wasn't satisfactory. It didn't address all of the points in the question. And I think the working group that Julie has now flagged will be immensely helpful, because I think what happens at the regional meeting is we are one voice in many. This will actually force the issue about focusing on what's happening in Shropshire at a local level. So I welcome that. I think that'll be really helpful.
Okay, thank you. Any further questions on the finance and contracting report? Graham, sorry.
Could I just ask Julie, I'm getting pretty inundated with the complaints from patients. If you're having a group put together to look at this, could you involve a patient on it?
Yeah, there's been patient representation on the historic group, and there will be in the new group as well. Yeah.
Okay.
Yeah.
Okay. Thank you. Any further questions on the finance and contracting paper? No? If not, we'll note its contents and we'll move on to the paper on QUIP, the progress report on our quality, innovation, productivity and prevention.
Thank you. So once again, these are our month 8 numbers up to the end of November. And once again, I'm not reporting a material move in the forecast outturn position against our QUIP programme. So at the moment, what's embedded in our finance position is an assessment of an outturn of £18 million worth of savings against our initial plan of 20.5 million. Now, we had quite a lengthy debate at the Finance Committee because a lot of the work that we're doing at the moment, and as I've already highlighted in the finance report, is very much about testing the reasonableness of our assumptions about what can be delivered over that final quarter of the year. And certainly for some of our QUIP schemes, there is an element of delivery savings anticipated for the back end of the year that if we're not fleet of foot or if we're not able to pull those through, that will impact on our finance position. When we made our risk assessments for month 8, as part of the risk that we reported in the finance, which was a total risk to our position of 4.6 million, we'd got an element of QUIP non-delivery in there, so we were highlighting that there were some elements of our forecast delivery for QUIP that we have some concerns or doubts about that delivery, and that risk assessment was 1.9 million. So to put that into context, in terms of that overall programme of work for QUIP, we think that our forecast outturn at the end of the financial year will be somewhere between a 2.5 million deficit against the original plan of savings and the 4.4 million, which is that risk assessed piece. We have a number of mechanisms in place to manage that, to try to reduce the risk as much as possible, and certainly this isn't a context of things that are all slipping or all won't happen, I go back to that original point I made in the finance presentation about the fact that there are only so many hours in a day, and every day that ticks off the list is one less day for opportunity of savings. We do have some things in there that we will assess and close, and they will be projects that, for whatever reason, haven't got off the ground. We also have a number of things in here that it's purely about the timing, as I've already said. So whilst we may not be able to secure those savings in this financial year, what we will be doing is rolling that assessment forward, and it will contribute to the position for next financial year. So again, and I've said this in previous meetings, we cannot see 31st of March as a cliff edge or a closed door. We have a rolling programme of work that we're contributing to. That's probably as much as I wanted to say, other than to reflect back to governing body the continued efforts to work on the programme for 1920. We work in a little bit of a vacuum because at the moment I can't give you what the number is in terms of the size of the gap in the finances without having all those jigsaw puzzle pieces, as I've mentioned. But we are going full steam ahead at that programme of work and building that from the bottom up. And indeed, yesterday we had a full day session with directors and senior leads for the project so that we could have a really good look both at this year's schemes and the schemes listed for next year. But I'm happy to take any questions at that point.
Sarah.
I'm not sure you'll be able to answer this one, Claire, but just under the MSK piece, there's just a very small piece that said we're looking at a viable plan B. What might that look like?
I look to Julie again for some help with that.
Okay. We've had a number of meetings with our colleagues at Robert Jones because the operational delivery of the SUS service is not working in the way that we envisaged or in the way that is working elsewhere in the country. Simon had a really useful meeting with Mark Brandreth between Christmas and New Year, and we have agreed that we're going to look at... Sorry?
And again last night.
And again last night, which I've not the latest update, but from certainly the meeting between Christmas and New Year, we've agreed that as to how we need to have a very senior transformation group, clinically and accountable officer led, that's really going to drive that forward to get us to that place, because through our local arrangements we've kind of got it so far and we're still struggling to get that real change in clinical behaviour at the highest level, and we're confident now that will be much more effective.
So is Plan B just an approach to how we get SUS embedded, or is Plan B something
in the first instance? Ultimately, as we've said, if we can't replicate what's seen elsewhere, because we know we are such a significant outlier from our right care and all the other indicators, then we will have to seek to find an alternative provider for that service. That's clearly not our preferred option, and Robert Jones know that, but we know that as a system we can't carry on as we are.
William and then Keith.
Thank you. On looking at the monthly quick performance, it looks like there was a sort of a dip, particularly in November. I was wondering whether there was anything, one sort of particular thing behind that, or if it's a general shortfall across a number of projects.
There wasn't anything particular that came out through the meetings that we had in the run-up to this. I think it's just a product of where we're at. Certainly the forecasts are based on the year to date, but also the intelligence about what's going to happen for the rest of the year. So there was nothing flagged to me that was a concern that would have influenced the forecast.
Keith, sorry.
My query was about MSK again, and I understand the point you're saying, Julie, about trying to work more effectively with Robert Jones, but my personal view would be is if that's not delivering, then we should seek another provider, not as a reluctant thing, but actually on the behalf of the best interests of 300,000 people in Shropshire.
Okay. Graham.
Yeah, very disappointing this, because I think when we set SUS up, we had every confidence it was going to be the answer. But I agree, if they aren't delivering, we must move away. I've had reason to take my wife there twice, been referred from the GP for her knees. The GP had x-rays done. Knees were in bad condition, but we can't send you to a consultant. You must go to SOS. Fine. I've taken her twice. They don't even have access to the x-rays. I mean, that's a fundamental. They cannot they cannot access x-rays done at SAF. So I've seen, a doctor on 2 occasions. Well, the x-rays were done at SAF through the GP, and he's asking all sorts of questions. I said, well, have you seen the x-rays?
I have to ask Judy to take that away, because
Would
Robert
you take
Jones
it away?
can Robert Jones can look at the
It's
SAF
just
x-rays.
unbelievable, really, isn't it?
Yeah. That is, yes. I've got sorry. I've got a few questions as well. So we'll get back to you on that, because it's a patient care issue as well, so I think it's important. Just to clarify exactly what Deloitte's are doing with the BCF and what the problems are with the BCF is the first one. Obviously, Deloitte's helped us establish the BCF, and it's a key bit of working with the council, isn't it, I think?
Deloitte's have got a lot of experience in looking at BCFs around the country, and therefore I thought it would be helpful if they had a look at ours. I think it's has considerable grounds for improvement, I think, and therefore we're just going to have a drains up look at it, how it's performing, particularly how it's governed. So, for example, a true BCF should have a single pooled budget with a governance structure. We don't have that in Shropshire. We've never had it. So I think it's an attempt to really just say, to go back to first principles and say, what ought we to be doing, how does it look, and what areas for improvement does it present to us?
Yeah. Okay. My second question is about the alliance agreement.
And it's not costing us any money, is it? I didn't think it was. I might be wrong on that point.
Yeah. We'll strike that from the record.
It's only costing us a very small amount.
It's not material.
The alliance agreement, this is the same alliance agreement that's going to be used about Shropshire Care Close to Home, is that correct? And obviously, is the saving in there isn't tied up with activity in the Care Close to Home, it's an extra on top, is it? Or quite? And is that one of the blocks that's actually affecting the alliance agreement being signed off? The amount of this sort of money we want to recoup from the Community Trust?
Yeah. The entry in here was an anticipation that we could release savings in year from the commencement of some of the pilot work and some of the other work that we're doing with Shropshire Community. I have to say that is one of the areas that's currently sitting in our risk assessment in terms of our ability to release that saving in year. And again, in part is related to the timing of getting some of the work off the ground. We've heard about that today.
Yeah, it's going to be quite hard if we sign the agreement in January the 31st
absolutely.
to save £150,000 a month.
Absolutely. So one of the actions that was taken away by one of the senior team yesterday was to go and nail down what we think the a more realistic outturn will be, but until we've got that is red risk assessed in this position as 100% likely not to happen, because I need some greater assurance on that delivery before I build it into the finance position.
So we're assuming it's not happening at all in the plans, that's fine.
For the finance, yeah. But again, that's a good example of one of the areas where we know that there will be savings released from reduction in admissions, so that's not a closed door at the end of this year. It will just roll forward into that programme of work for the future.
Okay. And then if I can indulge with one final question. On paragraph 6 we talk about an assessment of all the schemes that happen to check their fine. Is that talking about the assessment that happened this week, or was that a previous assessment?
That's work that's been ongoing since well before Christmas. So we had a set of gateway reviews in the run-up to Christmas for each of the project areas. And then the session that we had this week is, in essence, another gateway review.
But with it was review.
Yeah.
So it wasn't another review because there's a problem. The session this week was actually to follow on from all these ongoing reviews.
Yes.
Right. Okay. That's fine. Any further questions from the board? If not, we're asked to note the contents of the report, and obviously CWIP's going to be a challenge, and obviously the next few months will be interesting. And then we move on to the corporate performance report, which Julie's going to present.
Thank you, Chair. Compared to the previous governing body report, I'm pleased to say that we have seen an improvement in our 18 weeks, and the CCG is achieving that, so I don't intend to, other than the next paper that covers the high-level points, to dwell on that. We have continued to see challenges, particularly around the cancer performance, and again, there's a separate paper that will go into the detail and the work that we're doing with our colleagues at Shrewsbury and Telford Hospital to recover that position. Obviously, A&E performance continues to be a concern, and since writing the report, although we said about demand being slightly above plan in months 2 to 8, we have seen an increase at month 9, and again, that's what's triggered the work to understand that demand. It's not necessarily out of kilter with trends across the region, but clearly, given our already significant challenges as a provider and workforce, then anything over and above that in terms of planned level of activity, and at the moment it's looking to be anywhere. I think we probably planned for up to about 8%, and at the moment it's looking at about sort of 10 to 12% above. So it's just that little extra that's adding to the pressure there that we need to understand. And equally, I'll raise the point around ambulance handovers. That's inextricably linked to peak volumes. Again, there was an occasion last night where Princess Royal received 20 ambulances within a couple of hours, which is significantly higher than the whole department was ever designed to take. So, however, having halos, having handover nurses, etc., from a physical logistics point of view, that is always going to cause problems. I am pleased to say that the support from the National Emergency Care Improvement Team continues. They've drafted in their ambulance lead that's also going to support the work that I mentioned earlier, and is also continuing to work and support us on handovers. So where we see that demand at a more manageable level, we are seeing the handovers coming down, but at those peak times, it's still very, very challenging to be able to cover that. We are, again, that's not dissimilar to pressures that other trusts are seeing across the region. So happy to take any specific questions, but I just wanted to give that update on demand for ED.
Jess, sorry.
On the ED thing, under that section, we've got a little bit about the action plans and target areas for the A&E delivery group.
Yeah.
And we've also, in the papers for information, got the minutes from the meeting, most recent.
The A&E delivery board, yeah.
And it seems to me, as somebody who doesn't attend that meeting, so I was only getting an impression from the papers and the reporting, that the emphasis on actions is almost exclusively external. There's an awful lot of emphasis on things that partners should be doing. It projects, particularly in the minutes of the group, it projects kind of a real lack of ownership of internal processes, internal actions that could be taken. I'm putting that together in my mind with the difficulty that we have with that group actually aligning short-term actions with long-term strategic direction from both commissioners, and an ability to come up with sustainable solutions because they're not aligning with the long-term solution, long-term direction, and the month-on-month poorer performance. And I'm just wondering, is this actually working? Are we getting what we need out of this group? I know that we've got all the experts in the world available to us, but are we actually being effective? Is this the best way to see improvements, or are there things that we need to see change there?
I think there's two parts to that. If I'm honest, I think there is a disconnect between the A&E board and the A&E delivery group. I think colleagues who attend the delivery group will know that the agenda there is very much focused on the schemes as identified in the report. So we do get exception reports, we do get the detail on the systems and processes and the internal actions, the work around stranded patients. I have raised in the last week actually with Claire Auld that I think it's timely for an update to the governing body in terms of the work from ESIP, because I think what we don't have is, we know that work's going on, but the sort of broader system isn't cited on what those findings are and exactly what's being done to deliver it. So, for example, we discussed last night, we know there's a paper going to SAS exec team this morning around particular staffing challenges and pressures in ED. That's not visible outside of this. I think we do need to have a discussion about how we have that conversation. Do we have that conversation 3 times? So does Claire make a representation to our governing body, Telford's governing body and SAS, or do we potentially look at something where we bring the 3 parties together? Because I think there is there is a difference at the moment in terms of the way that's being reported across the system, and I'm not sure it's as helpful as it could be.
Unless you can sort of clone yourself and learn lots of different skills and go and work in lots of departments in SAF, I'm struggling to see, we're doing, I think we seem to be doing a lot, and we'll talk about it in the quality report, but we don't make any progress with SAF, and it really builds on what Jess was saying. I mean, you look at the breast 2-week, and, that's appalling. We know that, 4 or 5 months ago we hit a sort of a 30 or 35% as well, and the answer there was, well, there's not enough radiologists, or the machine's broken down, or there's the wrong patients, and yet the same thing has happened again. And their comment that, they're having, processes have been introduced to manage patient treatments lists as effectively as possible. Well, they're not really working, are they? Because it's down to 35%. And I think you then look at the other things as well, that, there's the A&E, there's the attitude that, we can't cope because there's too many ambulances at the front door. Well, that there are ambulances there, and they have to somehow deal with it. And
I was going to say, and that's a physical logistics question. Back to the original question around cancer, I'll prefer
I think it's
to
all
cover
the
that
same
under
principles.
the paper.
It's more about this sort of, it goes back to just the point about this, they're externalising things, and they're saying, well, these things are being done to us.
There's 2 things. I think around cancer, there have been issues that we have spent a lot of time over the past 6 weeks requesting their detailed action plans. I can assure the governing body that the first draft that we had, we weren't happy with, and we sent those back. We've had a second iteration that we're commenting on at the moment. I'm still one recovery plan missing, which is for urology, and that is a significant concern for me, and I've escalated that to my executive counterpart today, because without urology, the 62-day will not recover. The volume is so significant for urology, that's absolutely crucial for that. So, yes, I do have some concerns. I have some concerns that operationally, because of all the pressures around urgent care and both EDs, that's causing that's caused a loss of focus. There's an argument to be made about relative clinical priorities associated with planned and elective care, but I think everybody's committed that cancer performance absolutely has to have equivalent priority. I don't believe that. I think that's potentially lost some of its way. I do believe over the past 6 weeks that has started to be addressed within the trust, but we have yet to see the benefit. I can report, and I think I do in the cancer, that there has been a significant improvement in the backlog that was related to CT reporting. But again, that's just a snapshot. I won't be assured, and I certainly wouldn't pass on that assurance to governing body until I know that that's significantly down and it's being maintained and it's sustainable. Because at the moment, everything is too fragile.
Yeah. I mean, I do just worry that, I remember in 2015 being at Lion Keys and being very excited because Wayne Greenwood had come back because he'd had an A&E plan and it hadn't worked, and SAF had done their own plan, and then he'd come back, and I remember him standing there, I remember it very well, and he had a PowerPoint with a graph showing when we were going to hit our target, and it was just the same thing, every few months being sort of cycled around. And I don't know whether it's a question that whether we're failing or whether it's SAF failing or whether it's a system failure, but I'm struggling to know what we could be doing more of, and I don't know if, Simon, do you have a view on, should we be expecting more from the system, or is just this the way it is and we just accept it?
I mean, you know, there's a number of, we've attempted, so we sit on the South Oversight and Safety Committee run by NHSI. And I'm not totally sure how that's functioning and whether the trust, you know, whether we're truly getting to a shared view of safety, which I think is important. And there's an oversight group next Tuesday, which we will be making appropriate representations at. Short of writing to the group or NHS England, I'm not really sure what more we can do, personally.
Okay. Well, I think writing to, I mean, we'll talk about the quality reports in a minute, but I think, yeah, maybe that what, you know, we should, well, we do need to write to the quality oversight group really as a board, perhaps through the medical director. Finola.
I was just going to support Simon and Julian's point as well, in that I think we keep going, we keep challenging. I think the bottom line is that we can't say we're assured, and I know we haven't gone on to discuss quality specifically yet, but of course the performance report does make uncomfortable reading, and there is a sense of Groundhog Day about several of these issues. And I think we would be neglecting our duty as clinicians and also as governing body members if we didn't continue to challenge and question why we are where we are. And whatever it takes to keep challenging, we keep doing that until we are assured.
Okay, thank you for that. Any further comments or questions from the board? Graham, sorry.
Needless to say, the situation from a patient perspective is totally unacceptable, but I do understand the reason. I've been involved long enough, but I have some questions, but they'd be better raised under 17 and 18, I think.
Yeah, no, that's fine. We can raise them
Okay.
there. Yeah, that's fine.
I mean, they're all related to what we're talking about.
It is, yeah, the overlap between the performance, the quality, and the
yeah, there's duplication.
Yeah, no. Rod.
Do you want the questions associated with cancer when the cancer paper comes up?
If about cancer performance, or I think now really, yeah. The cancer service update is more about an action plan.
One of the things for me around the cancer action plan and the cancer data is what does that actually mean for the patients in question? If the target, for example, is 2 weeks and it's 15 days, then that may not be critical. But I would want the reassurance that in terms of any of those patients that the trust has followed them up in a way that's appropriate to their clinical need. And I'd be seeking that formal assurance from them so that we're looking at real people as opposed to just the numbers.
And that does flow through the clinical quality review, absolutely, Rod, yeah.
So it isn't an absolute, it's not 100%, is it?
Yeah. But part of the reason for saying that is that one of the reasons we hold these meetings in public is so that our colleagues in the public understand what we're trying to do to deal with the situation, and also this balance between worrying patients about attending a local service, because there are many of the things that our local services do that are good, and that our patient groups will come back to us and say they've had good quality care. But equally, in those cases where they haven't had good quality care, we want to make sure we're not scaring people off from attending services.
So just to be clear, though, the cancer targets, right? The cancer targets are not. So, for example, if you look at the 62-day target, which is a target from urgent referral to first treatment, it's not 100% of patients. The reason why it's not 100% of patients is some of the patients are very complex and well, the GPs will speak to this better than I, very complex and difficult to diagnose cancers. So you can't actually do all of them within a particular time. So the idea of the measure is to trade off getting everybody treated as soon as possible while taking account of the fact that there are clinical exceptions. Now, with the 62-day target, for example, the Trust do have to report any breaches over 100 days, don't they? Which is looking at long stops. But generally speaking, the long stops generally are very difficult diagnoses or complex diagnoses, or the patient is can't be treated because they're too unwell to be treated, or whatever the issue is. But that is gone through at the CQRM in some detail.
Thanks, Simon.
But what I am saying is, where the trust is missing a target for 2 weeks, it's missing the target with the allowance for those exceptions, and therefore the trust is missing the target. Yeah.
Absolutely. And it's that subtlety I want to make sure that we're clear about as a board, and in terms of the information that goes to the public, and so that our focus is both on the overall performance, but what it means for individual patients. And I know from the conversations that Julie and I have that that's one of the key things that she's been picking up on, but I wanted to make sure that was clear. The other one that's coming to me, which isn't picked up in here, and we may need to do, is Gail and I have had a brief conversation about some concerns that are being raised for us in relation to armed forces and the Armed Forces Covenant, and military personnel not being able to access treatment in the way that they would like. Outside of the meeting, we'll follow up the particulars of that, but it does touch on an issue that's of importance to our armed forces colleagues and the requirements that collectively we've signed up to. The other one that's I'm not looking for detail today, but I would be grateful if we can pick this up outside the meeting. I was noticing the continuing issue about E. coli. And whilst our performance on other healthcare-associated infections appears to be generally very good, I'm just interested to see that the numbers are going in the wrong direction, and there's been a couple of spikes. So I'd be grateful for a conversation outside of the meeting on that.
Yeah, we pick that up because I'll link that in with my colleagues in infection control on that, Rod. Yeah.
Okay, thank you. William.
Thank you. IAPT, I know we're going to not achieve the 90% target this year, but the aim was to achieve the run rate equivalent of that 90% target by year end. And in the report it says that's dependent on recruitment within Q3. As Q3 is now over, did they manage to recruit the staff?
We've not had the contract meeting in January yet, but that is on the agenda for us to follow up with that, and I'll obviously circulate an update following that meeting, Will.
Thank you.
Thank you. Michael.
Can I just point out that we should remember that the staff are struggling as well, and that's not always their fault that there's something wrong. We need to make that clear that the staff are doing what they can do. I think we have to protect them as well as criticise the system that's ongoing.
No, definitely. I mean, the staff are working tirelessly and all working very hard. And I think it would be very hard to find anyone in staff who wasn't working above and beyond the expectations, really. So that's taken as read. And I suppose it's the corporate performance, these particular factors that we're measured on, really, isn't it? As, you know, but yes. If there's no further questions, then we'll...
just to add to that point, we owe it to them. We owe it to the staff as well to make sure that these services are delivering, because if they're in such a fragile state, it's very difficult for them to do the job the way they want to do it.
I think they're in a vulnerable position because they can be overused. Yeah. And I think they're in a vulnerable position.
Yeah. That's right. So unless there's further comments, then we're asked to note the contents of the report and the actions within it, which is good. And then we move on to the next paper, which is elective waiting time management, which is a positive story from South, which is good.
It is, at least for the time being.
South being our main provider.
Yes, until obviously we get lots of cancellations for winter pressures. No, it is. The one thing that I did just want to reiterate was there's obviously within this year there were less focus from our regulators around absolute referral to treatment performance and more on the total numbers of incompletes on the waiting list at the end of March 2019 versus the position we had at the end of March 2018. We would anticipate a slight increase in the autumn, as I reported at the governing body last time. We're slightly concerned that that's been extended. So at our planned care working group at the end of December, we met and we've agreed to do a piece of analysis that's going to understand that and share that with their Assistant Chief Operating Officer and work through that and go through that in detail at the end of January's meeting. So that's just to assure the governing body that we know that's a critical indicator. that extra analysis is being undertaken. We'll report that through to the Finance and Performance Committee in February and obviously bring that back to governing body in March.
That's good. Two of the slightly negative things in the long-term report were, one, veterans were mentioned on about the last page as the first mention for the long-term plan, but also I see that they're saying they're planning to, in the spirit of incentivising people doing poorly to do better, they're planning to fine both CCGs and trusts for 52-week waits,
yes,
to reintroduce the old system of penalising everyone.
Yes.
So that's
yeah,
wonderful.
Well, on the 52-week
The
wait,
history of leveraging penalties isn't a great one, though, is it?
I think it actually worked quite well on 52 weeks, I think, with providers. I would say the good news is we've seen a significant improvement in our out of area. We get very, very occasional over 52-week waits now, and there's two causes for that at Robert Jones. One is if it's a particular complex spinal patient where for either linked to the nature of the surgery or for the patient choice, they choose to wait because of how it fits into their lifestyle, because it can be a fairly substantial procedure. And the other thing is a type of treatment, and forgive me, I'm not a clinician, but there's something where they have to grow cells in a lab to reinsert in people's joints. And again, unfortunately, biological processes don't respond well to NHS England targets, and that time scale is longer than that. So occasionally for that treatment, I think we've got one patient at the moment that was dated in March that would have been over 52 weeks, and unfortunately that particular batch of cells has not grown in the way that it should, so we've got a problem with that. So, but we're literally talking that exception. If quite frankly, if they fine us for that, then I give up, because there's not a lot we can do about that. I'm sure that should be within a reasonable bounds of clinical exception, given that it's the time taken for a clinical process to be concluded. But I'm confident that in terms of the processes we have locally and how we put the challenge in, not only to our local providers, but for Shropshire patients that choose to go out of county, we have a grip on this on a weekly basis and are always chasing those treatment dates for our patients.
Good, thank you. Unless there's any further questions, then we're asked to note the contents of the report and the work underway to recover the incomplete total by the end of Q4. So thank you for that, Julie. We then move on to the quality exception report, and as stated before, Dawn unfortunately is unwell today, so Sam Bunyan has stepped in. So thank you for doing that at the last minute, and obviously we'll need to recognise that it was Dawn that prepared for the meeting. But thank you.
Thank you. So the board are invited to review the quality report, and I'd just like to ask for your attention on a couple of points. As we know, the PRH didn't close the emergency department overnight, as they had reported they had secured sufficient long-term locum middle-grade doctors. We raised concerns about the sustainability of that plan at their CQRM, and the burden of risk and the challenges placed on substantive staff in the short and medium term. In addition to that, concerns were also raised about the assurance on a robust induction and support process for locum staff groups. SAF had also reported an over-recruitment in some areas to mitigate issues with the acknowledged unreliability of locum staff. And initially we had some evidence of this from the daily Safe Today reports. We also received a workforce plan from Emergency Department to gain assurance for the forthcoming weeks, and that is detailed in the report below. Over the last few weeks, as we know, there's been quite a few challenges to Emergency Department in terms of staffing, and so our concerns regarding the sustainability of the middle grade locums is still stands. We have been in contact with SAF on an almost daily basis through the Safe Today reports and also through the Emergency Department working groups to look at this and to gain assurances on it. Along with that were concerns about the emergency staff being qualified in advanced paediatric life support, and we have been provided assurance on this and from the CQC, and myself, I have actually done a couple of assurance visits at the emergency department and spoken with staff and gained assurance that they do have qualifications in paediatric life support. Coroner Regulation 28 letter had been received regarding sepsis, and as we've already discussed, it concerns some problems with IT systems and shared patient information between departments, services and WMIS and Shropdoc. There are meetings in place to have a look at the problems and how to address this going forward, and we will report back on that as the information is received. Robert Jones and Agnes Hunt, the CQC conducted their visit on the 28th of November, and the report is awaited, but no concerns have been raised with the CCG on that visit till now. Shropshire Community Health Trust, the CQC lead had requested a meeting with the CCG Director of Nursing and Quality in advance of their visit, and information again is provided in the report. Midlands Partnership Foundation Trust, the CCG has advised that additional external psychiatric support is being identified by NHS England to support the mobilisation of the 0 to 25 service. As we've already heard, concerns regarding the pace of change continue to be raised at the CQRM, and there is a task and finish group to be convened to ensure adequate assurance is obtained on that. As we've already discussed on the MPFT concerns and report on the 0 to 25 medicines management, the details within the quality report, but I think we've already heard from Steve Trenchard on that particular item. NHS 111, we have had some concerns about the end-of-life patient navigation through the 111 service. We are aware of that, as are the relevant parties, and there are meetings ongoing to address that and how that can be improved. Is there any questions?
Thank you. Questions? Jess?
I just wanted to add a couple of points to that, actually. The first is just a little bit of additional clarification around the assurance that was given to us about PEDS skills, particularly for the RSH site where they don't have PEDS on site. We were sent further information about the training that's offered at induction, which is a refresh of basic life support training, not advanced life support training. We were sent a breakdown of the compliance with APLS training for the substantive staff, but obviously that doesn't speak to the skill mix for the locum doctors that are working there. The way that they plan it is to always have the shift managing nurse be somebody who is trained in APLS, so somebody on each shift should have those skills. However, it's worth reflecting that we do recognise this is a really fragile service. We are having difficulties with staff not always attending. It doesn't take very much to destabilise that cover. And whilst that isn't on each shift necessarily a problem, it only has to happen once for it to be a serious incident. So we just have to be mindful that the assurance we've been given is to my mind, partial, and is dependent on stability within a very fragile and imperfect system at the moment. The other thing that I would want... Go away. I'm doing this electronically. And the other thing that's worth highlighting, Dawn sent this through, and I know, Sam, you're very aware of this, but there's another piece of work that's going to have to take place with regards to the processes we have noticed in SAF around X-ray reporting. There have been a couple of delayed diagnoses as a result of a failure to actually look at the reports that have been produced, and it seems that there are endemic processes that mean there's no fail-safe there. We're going to, as a quality team, we're going to have to really get involved in that and make sure that that's improved, because there is a significant risk there at the moment that the board should be aware of. And then the final thing is, we've mentioned the Save Today calls. We have to consider whether we want to increase the frequency of those, or whether we find that we're escalating appropriately. It's not necessarily about the metrics we request, it's about the evidence underlying that allows us to test whether what we're being told is actually the truth. We do need to keep pushing on that, and we do need to keep pushing for SAF to enact their business continuity plan at times of pressure when they need to. We have to have a defined understanding of what safety is and then push them to utilise their business continuity plan. And I think just as a board, we need to make sure that we're giving the remit to quality to actually do that and hold a firm line.
Thank you. Questions? Graham.
Yes. Item 16 in this report is quality assurance visit to A&E. The last paragraph brings dear old 111 into focus again. Common theme around patient expectation at E&D. It was discussed by several staff members that NHS 111 was providing inconsistent advice and inappropriate referrals to ED. This results in patients having an unrealistic belief of what the ED service would be offered. Really, staff obviously still do not understand fundamentally how 111 works. So patients also don't understand, but how you get patients. Can we ensure that all the staff working in those areas fully understand what is appropriate and isn't inappropriate referral from 111? I think I know the answer, but it's all right looking, all the work you're doing on 111, looking at what I call the hard points, too many people, too many ambulances, and get them right. But it's the soft underbelly as how this is also affecting patients, and they're getting unrealistic. Can I just have some assurance we're going to look at the softer issues in this area?
We've actually done a bit of work behind that since this report's been released. The issue is obviously because it's been over the Christmas period, and there are challenges already within the services without us adding to the issues they've got.
Okay. No, I understand
The problem with the advice that's being given from 111 is that their recommendation is that they contact a provider within 1 hour. And the patient expectation and their understanding of that is that they should be treated within 1 hour. So we're working closely with the team to clarify that a bit more so that there's a bit more of information being provided when that piece of information is passed to patients. So it's an understanding that they should present themselves to a provider, to a service, whether that's urgent care or whether that's at A&E or Shropshire, who they need to contact within 1 hour rather than receiving treatment within 1 hour. The other issue about the staff is that there is a way to report any inconsistencies or concerns with the 111 service, but we haven't been assured that staff are aware of this reporting mechanism. So while they spoke to us anecdotally when we were in doing our assurance visits, there isn't a formal procedure for staff to raise any concerns with 111 service, or at least there's a formal process in place, but they're unaware of it. So we're working now with the ED department to pass that information on to them to try and see if we can improve communications.
You know, if this was a brand new service just being introduced, I could understand that. 111 have been sending patients to A&E for the last 4 years. They're sending more now because of not using the Shropshire number. Can we have some feedback as to what actually has happened rather than saying we will, as to whether staff have been updated, are made aware of it?
Yeah.
Because we can say we'll do this, this and this, but it would be nice to have feedback if we've actually done it.
Yeah, we can do that for the next report.
It's frustrating, but fully understandable.
Thank you. Finola, then Steve.
Thank you. I mean, I think a lot of this just illustrates as we've already alluded to, clearly South is still in a fragile state, despite what they've implemented in terms of their workforce model and being able to keep PRH open. And we have to obviously continue to closely monitor that. There's obviously been an increase in demand that perhaps wasn't entirely accounted for by the planning that was done. And that's not necessarily their fault, as it were. But I suppose my question is, how do we continue to monitor this? Jess alluded to the sort of Safe Today calls that we started in August, where we were able to look at information on a daily basis and challenge that. but it wasn't necessarily all that meaningful. And we still, even now, I think, struggle to get the information we need to assure ourselves that things are safe. And we're going back to that again. So I wonder what, have we clarified what we need to do as a governing body today to ensure that we support SATH fully, but equally challenge in the right way and get the staff and get the patients and get our monitoring of this to a better place.
I think if we come back to it, Simon's just appeared, because I think that's a question really for Simon. It's for now just a question about what more do we need to be doing really to assure ourselves that the right challenge, whilst we support SATH, that the right challenge is being put in place. And I think it comes back to our conversation around the oversight group, which obviously you attended, and whether we need to write into that.
I think it is a difficult balance, as the CCG needs to support SATH in a difficult set of circumstances, and particularly the frontline staff. However, we shouldn't lose sight of the fact we do have an obligation to patients and a statutory responsibility to assure safety. And where we think that safety is being compromised, then for whatever reason, then we need to raise that robustly and in an evidence-based way. So, as we said before, I think the first way to do that is for the people attending the IOG next week to do that. And if we don't think that's being done, we need to raise that formally with that group.
Steve.
I just wanted to raise the issue regarding IT systems, or the inadequacy of IT systems, which was highlighted by the risk review. It's been mentioned in this coroner's letter. I believe it also came up in another coroner's report. I think there's more than one coroner's report where it's come up in. I think it's generally understood that there has been underinvestment in IT within SATH for many years. What concerns me is there's very little seems to be happening about this, and this is a quality issue. It's causing problems with quality, and there doesn't seem to be the buy-in at a high level. How do we get that buy-in at a higher level to actually take this on board and do something about it?
Simon?
I think there are issues about IT systems, but I think I suspect they're overplayed. So, for example, as Sam will tell you, our attempts to get assurance on the proportion of rotas filled is not dependent on an IT system, because they must have that information to hand. They must have it to hand. So I think we're overplaying it. Yes, there are endemic issues there that need to be resolved, but I think we shouldn't allow the trust to hide behind that. I think there are things they can do within the constraints that we've got.
Yeah, I mean, it's in those terms, I totally agree with you, but it's more on the clinical basis and the movement of clinical information around the system.
Yeah, I mean, we shouldn't lose sight of the fact that most A&E systems are not clinical records. So they're not a clinical record in the sense of a GP system. They're just a record of when did they arrive. They then get a CAS card printed out that follows the patient round the A&E department, and the clinicians write on the CAS card. And then a summary is done back on the A&E system when the patient is discharged, and the CAS card is filed. So we don't have the national solution for a clinically rich A&E record is nowhere near where GP systems are, where the whole consultation, the whole record, the whole patient history is in the GP record, available to the GP, that's updated as the patient meets the GP. That's not what happens in A&E departments.
And it does I
think it is different.
Yeah, it does have to be easy to use, doesn't it? Because I think, Kevin, you report that SATH have got the ability to look at EMIS medical records, but they've never actually looked at your practice's medical records. And So I think it's got to be easy to use. I mean, there is some technology
Has
that's
to be
there
one
now.
system,
It's not there.
I think that is part of the problem, and that is due to the lack of investment. I mean, yeah, when you're supporting over 100 different systems within.
But it's also, you know, the National
One
Programme for
organisation.
IT did try to resolve that and failed spectacularly, didn't it? So the idea of MP Fit was that whichever hospital you went into, your record, your whole GP record, the whole kit and caboodle will be available, which was interesting, because actually, of course, if you look at the total number of patient interactions, Shropshire patients, 99.5% of their health interactions will occur in Shropshire. So, you know, the vast majority of patient contacts with health are through GPs. The number that's through hospitals is relatively small. So the idea of investing 30 billion so that when you went to Aberystwyth on holiday and happened to break your big toe was probably, you know, what we should have been doing is integrating local records.
Which is what I'm suggesting we need to be doing.
Absolutely.
And it is happening in other parts of the country.
It is, yeah.
And A&Es are working
there isn't a
electronically.
great track record of, so I've worked in other health economies where we've had full system one availability into A&E, and the experience there is exactly the same as Kevin's reported, is that people just don't use it.
Okay, that's brilliant. We've got Finola and then Jess.
Yeah, I think there's a difference also between, you know, the kind of large-scale, you know, multi-million pound, you know, electronic patient record that, you know, is the sort of state-of-the-art future thing that SATH kind of tends to defer their comments about IT to, and sort of make out that, well, you know, that's a business case and that's going to cost millions of pounds and we have to form a group and think about it, to the solutions that could be implemented tomorrow if they had the will to do it. And Steve and I have sat in the Risk Summit and made those very recommendations. We have also emailed them with those recommendations. They're not difficult things to do. A couple of computers would sort it out and would enable them to be able to share records for patients out in the community if they wanted to. It is such a risk that, you know, from a quality point of view, you would think it's a no-brainer to do something fairly straightforward and simple to move things forward and make care a little better. But we just don't seem to get any response to that.
Okay, so Jess.
Yeah, and I'm afraid I'm going to be another one banging that drum as well. We're not talking about an all singing, all dancing shared care record that tells everybody everything that happened in Edinburgh 20 years ago. But what we are saying is that we've got a system at present where X-ray reports are literally put in a box and then shredded. That is so unsafe and so archaic, there aren't even the words to describe it. We've got a system where literally hundreds of people fall off the end of an IT system. We've got no way of finding them again. That's not okay. Having live boards in A&E that actually are plugged into something and give real-time data about flow and the likelihood of breaches and where people are supposed to go and where the gaps are in the hospital, that's something that other hospitals are using, and they are enablers to better patient flow and better patient care. There is an absolute resistance in this system to do this. And again, like coming back to care close to home, this is not innovative, it's not new stuff, it's not radical, it's slightly different for Shropshire, and we have to stop being so frightened of different things. There is a gap in strategic digital leadership that we need to fill if we're going to actually be fit for the future.
Okay, got Keith.
I think the report that Sam outlines is really, really worrying. One of the things I reflected on was that at previous meetings and in the Quality Committee, when Dawn's been presenting, she said that she's not been able to give us full assurance. And part of that has been because of the delay in getting responses from SATH, or just not getting a response from SATH at all. Even when it's been escalated to you, Julian, or to Simon, and you have written to SATH, we have still had those problems. And I just wanted to flag that up again today and say, is that still the position? Because until we start getting that, I don't see how as a CCG we can ever reach full assurance about what's going on in SATH.
Okay, thank you. Simon, Doctor? I think it feeds into what we've been saying, that, you know, we are struggling to get assurance, and I think that's where one of the aspects we need to be feeding back into the group next week, really, the oversight group, and we need to keep pushing that, really. And it had possibly been suggested to me by NHS England that now we'd had the Risk Summit and we'd keeping PRH open, that perhaps we should move on from some of these issues. And I did flag to them that we were still worried about patient safety and quality and would continue to keep flagging it if we thought there were issues. Deborah.
Thanks. I just wanted to highlight a couple of other things. We're obviously, and for obvious reasons, very focused on problems in ED. But there are 3 small paragraphs here with concerns about other departments that we're not really hearing more about. So we've got paragraph 13 about obstetric services and obstetric anaesthesia. We've got paragraph 14 about several challenge specialties and stroke services, which I know is a concern to a lot of people in the public domain, and a never event in ophthalmology. And whilst I know a lot of our resources are focused on ED, I wondered if you could just say a little bit more about what these other concerns are and how we're monitoring and addressing those.
I can advise you about, because I'm not, obviously I was a last minute stand-in unfortunately, so I can't advise on some of the detail within the report because Dawn would be aware of that. I can give you some information about the ophthalmology never event. This was raised to us as not as a significant incident initially. When we looked at it in detail, we realised it was it should really be a never event, and that there was quite a lot of national learning to be had from this particular event. Without going into detail, there are not systems in place to adequately ensure that if there is eye surgery to be taking place, that the eye is marked. And this is national. This is not just doesn't pertain to SATH and ophthalmology. So while we recognise that there have been issues with ophthalmology, this particular never event, we do have assurance that this is something that would be affected, that has a national interest, which is why we've decided to escalate it to a never event. We're still awaiting the RCA on that to come back to us. There is a working group already in place at ophthalmology, and they already have given us assurances, and we are assured at this point that they have implemented immediate safer patient processes to ensure that this doesn't happen in the interim period before formal process and national learning is shared with the RCA.
Thank you. We do need to move on, but I did want to ask one other thing relevant to what Deborah was saying, really, that there are other providers, and there's a couple of things within the Robert Jones report that I think may need further clarification to come back. One was about the confidential information leak, and affecting a large number of patients, because obviously there's issues there around sort of IT and the problems. Then secondly, paragraph 19, which I think there's perhaps more to it if it's not particularly clear what we're talking about, whether these are 1 or 2 patients or large numbers of patients, but it does slightly worry me that you need legal advice on duty of candour and to have oversight of the process, and whether we could perhaps, I'm not saying you know any information now about it, but whether we can bring those back to a subsequent board meeting, really. Unless you know about.
Yeah, this is from a report that was prior to my arrival within the CCG, and again, Dawn is more aware about it.
So if we could bring that back for the next meeting,
yeah,
would be good. Give some more information about those.
Just now, or
no, if we can bring it back
for next time, yeah, I can
next
have that in the notes. Yeah.
So obviously, if we can note the content of this report, note our concerns about ongoing challenges around quality, note our concerns about not being able to get assurance around the safety of A&E and the action that the medical director, Dr. Sokos, will be writing to the oversight group with our concerns. And then we can move on to the cancer services update, which I think we've covered a lot of, haven't we?
Yeah, but I think there's a couple of key points.
My fault, Maine, if you're covering it.
Chair. One is to say, unfortunately, there's a couple of typos in the original version, but we did resend out just for the clarification. We are expecting recovery of the 2-week by the end of Q4 2018-19, not Q1, as it said on the front sheet. But I wanted to point out that there's kind of 2 elements to cancer. There's one, the very here and now recovery of what has, up until the last 6 months, historically, SATH have actually performed very well with cancer, and we shouldn't, whilst we have some concerns, we shouldn't lose sight of that, and we should. That's why we're keen to make the recovery.
Then there's obviously a second more strategic piece of work that's being coordinated by the Regional Alliance that's linked to a long-term cancer transformation plan that my colleague Gail is leading on. And we're making sure that this is kind of bringing this together. But the purpose of this report was just to identify what's our observations around the current 2-week and 62-day, and to make sure that obviously going forward the longer term sustainability of that cancer performance is inextricably linked to that work that we're doing as part of the Cancer Alliance. So in terms of the short term, I think it's fair to say that we have got a reasonable level of detail in terms of the underlying issues, particularly around the 2-week performance deterioration. And I wanted to give the governing body within the paper some assurance about the actions already taken and the fact that there is a reasonable level of confidence that that will be recovered by the end of Q4. However, 62-day, as I said earlier, continues to be more of an issue. And as I said, still at this point, we don't have the urology plan, which is key to that. I also wanted to remember that what's different this time is also NHS Improvement this time asked the cancer team to go into Saturn to do a deep dive. And we've, for the first time, I think, I'm quite pleased with this, we've got NHSI and NHSE to agree that we would just have one single plan for our cancer recovery, that we'd bring together the remedial action plans that we would require of the trust through our contractual routes, and the actions that came out of the NHSI deep dive, not least so that we've got one plan that's all coordinated, but equally so that we've got both sets of regulators driving for the same improvement. So I just wanted to make that point, and that they will be coming back in, particularly to support the trust around their redesign of their multidisciplinary teams, because that was found to be an area that where they were struggling for capacity and struggling in the way that they weren't working in a standardised way across the trust, and that's certainly something that NHS Improvement are going to need to continue to support the trust on, and are coming back in mid-January to follow up on that, so that will also be included in the future plan. But happy to take any other questions.
Thank you. Questions, Graham?
Yeah, the question I could have raised earlier when we were debating this one, but on page 4, item 11, there's been a large increase in referrals into urology for prostate cancer, and the trust only have one surgeon who can perform radical prostatectomy. There's an increased demand at all local tertiary centres and limited capacity available. Now, when I read that, I just wrote, we must have patients backing up now who need treatment.
Yes.
So I just wrote here, are we looking at sending those out of county at the moment? But then I returned over the page and read number 17, C, surgical capacity for urology, in brackets, due to developments in robotic surgery at tertiary centres means recruitment at a district hospital is severely affected. SAF are exploring long-term strategic partnership with University West Midlands, I think that is.
North Midlands, yeah.
North Midlands, sorry, to address and offer joint appointments. So that half answered the question I had down there, but that is long-term.
Yes.
What the hell are we doing between today and when you've got that agreement? Because
all of the patients, absolutely, all of those patients are being offered. No, patients are being offered and are being risk assessed, because what we are seeing is that although there is limited capacity, patients are offered alternatives.
Okay.
What we are seeing is that one of the things we've got to do is a significant amount of patient communication around this, because what we've picked up with the trust is a significant number of patients are choosing to wait and to have the treatment with this single-handed consultant, and that's one of the things that we've asked, and that's one of the reasons that we want to work through that plan. So absolutely those alternatives are offered. We need to ensure that the communication, that's kind of informed choice for patients, and they appreciate the risks associated with that, and they are any that choose to wait. We have sought and received limited assurance, I'm hoping for some more, that those patients continue to be assessed and are under clinical review by the consultant. The arrangement with UHM, again,
SAF are not on their own here, as we've seen that there's been quite a rapid take-up in terms of robotic surgery, particularly in urology. That has only been supported in a number of centres and not everywhere. So that is clearly making the centres with the robotics and now the newly qualified surgeons only use the robotics. That means that there's some limitations there. I'm led to believe that SAF and UHM have now agreed a memorandum of understanding which will underpin that longer term agreement so they can look at joint appointments, but ultimately where patients need robotic surgery, even under that they would have to have that surgery out of area. It would either be in Wolverhampton or UHM, and that comes back to there's quite a significant piece of work here around patient communication and engagement around this, so they're fully aware of the reasons why. What are the consequences of the choices and the decisions they make? So that is quite a significant piece of work.
Thank you. Vanessa, did you?
It's a different slant on the same problem, really. I gather that the Cancer Alliance has set up a number of working groups according to each of the cancer specialties. But what concerns me is that they all seem to be being led by chief execs of the tertiary centres. And in particular, urology by a very local tertiary centre. But I'm concerned whether rural CCGs are sufficiently represented on these groups to make sure that services are just not centralised for the convenience of doctors that like to do robotic surgery. Because I think that the large volume cancers, I mean, breast cancer is a really good example of how it has spread from the centres, and it is an excellent service across the country now. But
so I think each SDP is represented on these groups. As in my brief 15 months as SDP clinical lead, I was often being asked who was the
But
the
is
lead
it on
for
all
which.
of the groups?
I think whether there's the representatives
there
are
are
asked to
four
them.
priority sites, and we are represented on those, aren't we, Gail? Would you like to comment
So
on this?
I represent Shropshire and Telford and Wrekin on the West Midlands Cancer Alliance, along with Stephen McHugh, who's the clinician from SAF. So there's the steering group board that's chaired by the chief executive from Wolverhampton. What sits underneath that is an STP group, which is chaired by a clinician, and then we have an operational group. The operational group is delivering against the Shropshire, the wider Shropshire strategic cancer plan, but also that does look at where is the best place for patients to have surgery. Now that may mean that the majority of their care is in SAF, but the robotic element, because of the nature and the specificity of the machine, would be in UHM. So what's going on at the moment is we've got some money and we've got a team that I'm overseeing working against the 4 identified pathways to look at, you know, can this be delivered purely on a pathway within Shropshire? If not, why not? Can, you know, what would we need to do to invest? What would SAF need to do to invest? Is there the capacity, you know, is there the population need? If not, then where will these patients receive that treatment? And it's taking into account all of the cancer targets. You know, it's an option approach. We need to have a look at what the best outcomes guidance that we need to implement as part of the cancer strategy require. You know, but would we be right in assuming that putting a robot into SAF would recruit staff into SAF? That is one of the questions that we need to ask.
I think we're also going to have to accept the fact that in the future that more and more things will be so specialised they'll only be in limited centres. So like the genome bits are in 7 centres. There's but on the news there's like the Birmingham Lymphoma Centre that's now seeing 19,000 people with haematological cancers. So I think there is always this balance between localism and going further for specialist care. We need to make sure the right balance is achieved, really, and that networking's future's network.
It's the link to make sure they've got the continuity of care over the borders that are so
and I think that
important,
comes back to the discussion about the wider, the local versus the wider, you know, and just because Shropshire patients receive care at UHM or UHB or Wolverhampton doesn't mean that they should get less of a service, and you know that's very much what this piece of work's looking at.
Okay, thank you. I think Simon's got something to say.
Just, you know, in the paper itself, it's not acceptable in that paper or for SAF to say that these reductions in performance are due to patient choice. Patient choice is part of the reason why they're not 100%.
Yeah.
So that's not an unless there's been a demonstrable massive increase in people refusing to, so for the urology specialist, for example.
Yeah.
It's not relevant, and we shouldn't be putting it in here, and we shouldn't be allowing SAT to use it as an excuse.
And we don't use it as an excuse. There's a reason, because there are certain times of the year, particularly in holidays and over the festive season, where actually we do get a blip in patient choice and that, but we have to plan for that. As you say, it's part of the target.
I mean, it's one of two common
sort of excuse, but we have to understand it and do what we can to mitigate.
One of two frequent reasons they use. One is patient choice. One is the fact that there's a lot of patients without cancer being referred, but the NICE guidelines, I think, say it's about a 3% pickup rate, and in fact, in the long-term plan, it says again they want to lower that pickup rate. They want more people being referred to pick up more cancers overall, but with a lower percentage conversion into diagnoses. So I think it's frustrating when you go to meetings and SAF bring those two things up, because that's the whole point of the suspected cancer NICE.
And we've got to do the demand and capacity model.
Graham,
you're absolutely right. That demand will go up based on that.
Just a clarification. Is it right now that deaths from prostate cancer have overtaken those of breast cancer?
Rod?
Excuse me, my temperature's starting to drop. I would love to stay. I'd just like to thank you and your accountable officer for allowing me to listen and see what part of the operation is going on. But just I may add, I'm 70 years old. I was born in 48 when the NHS was formed. My mother's deathbed, who was a nurse for 27 years. My wife also died at the same time of bowel cancer, a nurse for 22 years. A little boy across from leukemia, spinal cord injury I had. I'm grateful for what the NHS does and gets right. And there's another thing with the NHS, which is nursing and commissioning care. I met in Ballinor with the most beautiful lady, Joy Tudor, 10 years ago. 2 months ago, I married that lady. But I'm sad to say that the treatment she's had from the clinical care commissioning and from care at home has been excellent from our surgery, of which you have to be a member of. But the care in the community is a big focus where money will be spent in the future. I pray that before you retire, Simon, that someone will look at a lady who, with so much love, I've had directors of your operation apologize to me for neglecting my wife and her care and support as well. It's 10 years we've been married. We've had apologies from people, but I'd like someone to look at the woman I love to see what that beautiful lady in a nursing home in Wellington with treatment that is nowhere near acceptable, but it's sensitive urgency. We are here and you are here because of us, clients, customers, patients, call us what we are. I supported the doctors when they were on strike. All my family are in the NHS in one way or another, leading positions in different positions. But when you're on the receiving end, you need to see and be an opportunity to get feedback. I appreciate that in your, at 4 o'clock, 5 o'clock this morning, I happened to see in the paper looking for a cleaner. I saw your article. I printed 208 pages of everything that came out of the machine. I ran out of ink eventually. I am talking too much, but I would like, before you retire, it's not a question of please look at the desperate situation that we're in, the discussions with the CCG, with different managers that have promised everything and told us we could have the care team that we selected 18 months ago as a record of excellence, whereby we've been given previously teams that really shouldn't be in business. And I'd like you to feel that it could be you.
Okay, thank you for those kind words. And we will ask that Dawn Clark, our Director of Nursing and Quality, gets back in touch with you when she's back from her sickness.
Right now, I want to get the girl home. I've been waiting
since
September 27th to get her home because of the breakdown of a care team that should be in prison.
No, okay.
Thank you anyway.
But we'll get Dawn to get in touch with you. But thank you.
Well said.
Are there any further comments about the Cancer Services Update report? If not, we can accept that. And oh yes, I was about to ask Professor Thompson about the incidents of. I was looking quite blankly because. Sorry?
Prostate is allegedly more than breast. But both rates are going down, but prostate is allegedly more.
Thank you very much for that. Question.
Commonest cancer in men, definitely, and that's taking all cancers into account. And
I would probably have to check on the Macmillan website myself for the actual final figures and things, but I trust.
In terms of Mike's point, yes, it looks as though it's just crept up as more common than breast cancer.
Anyway.
We shouldn't take the emphasis off breast cancer, but I think we should start bringing prostate up to get more of a...
No, thank you. Thank you for that. Thank you for providing the information. So we'll keep the cancer services under close review and take a further report in March, so thank you. We then move on to the CCG staff survey. Sam?
Thank you. I'm not going to rehearse the information that's in the report because I think that's fairly self-explanatory, and we'd be better to use the time for comments and thoughts from the governing body. I have reviewed all the individual comments from members of staff submitted as part of the survey, and in terms of my own observations, I was struck by, I think, how key the appraisals and one-to-ones are in terms of taking this work forward. I think if we can ensure that appraisals are happening for all members of staff and that the senior management team and managers as a whole across the organisation are enabling one-to-ones to happen on a regular basis, but also that staff themselves are encouraged to come forward, utilise those one-to-ones, and in fact raise issues that they may have with their managers so they can be taken forward and resolved, then we may find that the position is quite different in terms of future staff surveys, and that a number of the themes that have been evident could actually have been addressed quite positively through those routes. So the paper sets out a number of recommendations. This is really the beginning of this piece of work, which will be taken forward through the organisational development groups chaired by Sarah. And I imagine that this is going to be quite an evolving process as further detail comes through and we discuss and shape how to take this forward and make this meaningful for the organisation. But at this moment, I'd like to open this for discussion to the governing body.
Thank you very much, Keith.
I absolutely agree with you, Sam. I think the appraisals is key to this. And when a few meetings ago we were talking about regular HR information for the governing body, this is exactly the sort of thing I think that needs to be more visible, that we should get regular reports on the percentage of people who have now had their appraisal. So I very much welcome your report.
Okay, thank you. I'd like to obviously thank all the staff for all their hard work and thank the, I think 58% of the staff replied, didn't they, 90 staff, so it was a reasonably good response rate. I think I would have preferred the opportunity for the staff to put positive things in the survey as well as negative. They only got the ability to put written comments if they were not happy. Sometimes a few words of praise go with a few hits on the back, but I think they're a good set of actions, and I think it'd be good to have a report back detailing how they're going. So I won't read through all the actions, but I think we're asked just to note those 8 or 9 points of actions. So unless there's any further questions, we'll note that. Thank you. Next report is William Hutton and the Audit Committee report.
Thank you, Chair. So we have in the meeting pack, there's the summary of the last Audit Committee meeting on the 20th of December, and I'll just pull out a few key points from that summary. First of all, positive point here, you'll maybe recall we've talked about a number of outstanding actions that have arisen from internal audit recommendations around CHC complex care, and there was some concern about the progress on those. We had an update at the meeting in December, and there has been significant progress made. So I think that's a very sort of positive point to make, and I think it's important that I highlight here the thanks that the Audit Committee wants to make to the team for the work they've done on that, because I know it's not an easy piece of work. There's been a lot of work to rationalise and cleanse the data, so amongst other things. So thanks to the team for that. Second point I wanted to make, I think during November we received a letter from NHS England raising concerns about non-compliance within the CCG about approval processes for taking on agency staff. We've obviously had discussions around that internally, and it was talked about at the Audit Committee meeting. The Audit Committee was assured that we do now have procedures in place to provide the necessary controls, and obviously the Audit Committee will be monitoring that going forward to ensure that those controls are effective. In terms of internal audit reviews, we received 3 of those reviews at the last meeting. We received, and I think in all of those reviews, it's fair to say there's been significant progress when you compare this year to last year. So I think that's an important point to make. In terms of financial systems, we received overall significant assurance for the payroll and financial ledger aspects, and then moderate assurance for the accounts receivable and accounts payable aspects of that. And then for financial reporting and delivery, moderate assurance. From each of those reports, there's a number of actions that have been agreed to address the recommendations, and again, as always, the Audit Committee will continue to monitor completion of those actions. But I think all of those actions are in place, and many of them have already been undertaken. In terms of the Consolidated Financial Improvement Plan, you recall that it was agreed that the Audit Committee would provide assurances to the governing body on completion of the actions within that plan, and I can now report that those actions are largely complete, and I think any remaining work is now sort of business as usual within the finance function. We are still awaiting the Deloitte independent review report, which was commissioned by NHS England on the completion of those actions, and once we've received that, the intention will be to then close off that action. I'm not sure, Claire, whether there's been any more recent update on the timing
not yet.
of that.
It's in, Tony's got it on his list for this week to chase them, because we were expecting it before Christmas and it's not arrived.
And then following on from that, I just wanted to sort of highlight, as it were, I guess, the actions that, as a governing body, we need to consider that were recommended by the Audit Committee. I mentioned the considerable progress that's been made around CHC complex care, and I think it's important that we maintain that progress. And I think an important thing is that we need to make sure we've got adequate resourcing in place, because it is an area where we've made progress and perhaps slipped back sometimes in the past. So we need to make sure we maintain the right resource to maintain that progress. And also, I think we need to reach agreement on the 18-19 uplift with charges from the Shropshire Council, because that was one of the key areas that was still outstanding. And then following on from that, I think we need to make sure that we've got proper contracts and payment schedules in place and agreed with the Council, because a lot of work from the finance team has been put in this year in terms of sorting out those legacy issues, and it takes a lot more time to sort out the legacy issues than it does to put in place, hopefully, the proper payment schedules and processes to prevent them becoming legacy issues in future. And then lastly, just reiterating the point I made about agency workers, we need to make sure that the procedures across the organisation are adhered to in terms of the proper approvals for taking on agency workers. And that's obviously not just NHSE's approval requirement, but also it's important for us so we can demonstrate that we've gone through a due process to make sure we're achieving value for money from those sometimes costly resources.
I'd like to just say before Simon, I think looking at this, it feels much better than it did, and I said that at the last audit report. And I think the ones today, in key point 3, will just show, I think, the work that Claire and the team are doing. And I think it's obviously a bit like turning around a super tanker in terms of giving the assurance, and because it's the frequency of how it's done. But I'd like to just thank you and your team for that work, really. Simon?
The agency workers thing, of course, when you're under pressure from NHS England to bring people in as soon as possible to address issues that they see, you can't always hit every single possible governance and compliance issue. But I wouldn't want the board to think that this was a widespread issue. It just related to those specific individuals brought in on the support scheme from NHS England last year. So it's not. I don't think it's at all a major issue. And I was quite surprised that NHS England wrote to Will without even having the courtesy to speak to me first, which I thought was poor.
We do have, within our schedule of internal audit as well, workforce is in there, and the terms of reference have literally just been finalised. So one of the Q4 audits on workforce will include adherence to system and process, and I explicitly asked for a reference to, it already talked about testing our process, but I also made sure it says to include the NHS England bit of it. So again, we'll get some more feedback from an external source really on how well that's working, and if there's anything else that they can suggest we might want to do. So I think that will help too.
I might have misheard some, but I would have thought we'd expect to hit governance and compliance on all things, really. I don't think speed sometimes is reason not to have governance or compliance.
If people say to you, you need to get somebody in today, then that's fine, I'll get somebody in today. If you want me to go through a 3-week governance process, I can't do that, can I? So you can't, you can only do what you can do, really.
Yeah, no, I can appreciate time is a pressure, but we need to resist that, don't we, and go through some of our things. But any other comments on the audit report? Otherwise, we're asked to note it, and there's 3 points I think we're asked to note around ensuring CHC complex care is maintained, progress, ensuring the proper contracts are agreed with Shropshire Council, ensuring the procedures around the agency workers adhered to. So I think that we can agree that. And then we move on to Vanessa, who's going to bring the Health Watch report.
Thank you very much. As you will see, there have been a lot of changes within our small team over the last quarter, but we've tried to keep our focus on our priorities, and I think we're now better placed to move forward from now. In particular, we would really welcome the CCG's input to our planning work for the perinatal mental health engagement. But generally, I'm happy to take any questions.
Thank you. I read the report. It's very interesting. I read the attached report about ear syringing as well, or irrigation, and I think part of it is that Ponsonby is one of the practices that does ear syringing and didn't change its mind when asked, and that's because I think the receptionists were asked, and obviously I think probably no practices do syringing, it's all irrigation, but it's a very useful report highlighting, I think, one of the things that's a common problem that we get a lot of comments about, but in terms of medical problems is quite low down on the list, but it's quite high on the list.
On the public.
It's with toenail cutting, I think, and podiatry, which is another bane of every GP's life.
I think it was unfortunate that we did our piece of work at the same time as you were actually changing your...
I think it's a really good piece of work, and it's a good... to highlight the things.
As I say, it was something that the public was certainly concerned about, and the fact that there's evidence that things are moving to meet their needs is great.
Yeah, that's good. And obviously, did you say you'd like some input into the perinatal?
Yes, it's a piece of work that we've got to do in the next few months.
So presumably you're working with Fiona.
So it would be very timely. But Julie's just said that Steve Trenchard will certainly work with us on that, and that would be very helpful.
Excellent. Thank you. Any questions for about the health report? But thank you for that. It's a good update to read. Thank you. We then move on to a number of reports that are just attached for information there. The Clinical Commissioning Committee minutes from October and November, Finance and Performance from November, Primary Care Commissioning in October, Quality in October and November, A&E in October, a nice spread of months. And then the locality boards, there's reports in the South locality from October and November. So those reports are included. and just there for a comment. So if anyone's got any comments, or we'll just accept them for information. We move on. Obviously, the minutes had an extra bit at the end, which wasn't there because we did the questions at the beginning. So I've not been notified of any other business. So unless there's any other business, then draw this meeting to a close. The next meeting is Wednesday, the 13th of March, and we'll notify people of the time and venue via the website. So thank you. Good to hear positive things. Thank you. Thank you.